हाँ चलो. Good morning, everybody. First of all, I would like to thank you all for being here in such a short notice, because this conference was not planned too early. It was recently planned because of one of the international faculty was supposed to come with and be with us. So that's why we chose this date, but unfortunately he is also not able to come to the conference. But I would like to thank all the faculties and the delegates who made all the way to attend this conference. And to, uh, to start with the proceedings of the conference, I would like to invite our faculties, Dr. Unmesh Mahajan sir, Dr. Pradeep Chaudhary sir, Dr. Saket Jati sir, Dr. Hemant Mandovra sir, our Honorary Secretary of AOSI, Dr. Pranav Mahajan, Dr. Vivek Singh sir, who is HOD at R.D. Gardi Middle College, and Dr. Arjun Jain, please. So we'll start our proceedings with the lamp lighting. Thank you, everyone. Now I'd like to hand over the mic to Dr. Arjun Jain for the further proceedings of the conference. Thank you, sir.
A very good morning to everyone. As we have always had the best of our discussions and faculties from all over MP and surrounding states, we start our program for the MAC 2026 at Indore. So we start with our session 1 of unicompartmental knee arthroplasty, the surgical techniques and technology. For this, I would like to call upon stage the chairpersons, Dr. Pradeep Chaudhary sir to sit on the dais, Dr. Goya sir to have a seat, and Dr. Vivek sir to be on the dais as the chairperson. As we start this program for the new technologies of arthroplasty in the knee, the most important topic, as we all know, is about the patient selection. So I would like to call upon Dr. Unmesh Mahajan sir to start the session with a big round of applause.
Thank you, Vinay, and the organizing team for asking me to be here. Since we have two talks of me, one about the robotic UKR and the patient selection, and I have a panel discussion. I'll take few part of this two talks together, so it won't be repetition of anything. And then we can go on a panel discussion in detail about, yeah, robotic UKR. Because that's where the patient selection and everything starts. So. Okay. Yeah. Okay. So I used to do a UKR with navigation before, but now with Velis and with the UKR software, I think we have started doing more UKRs than before. So basically indications of UKR, a standard indication which should be worldwide. A standard is anteromedial osteoarthritis, medial femoral sponk, that is spontaneous osteonecrosis, post-traumatic medial OA, which is quite rare, unless there's only medial compartment involved, and medial OA with acute degenerative root tear. Now this last category of patients are coming up quite a lot, who are in early 60s. They have a medial OA, moderate to severe, with an acute root tear, and have an intact ACL. So these are the patients who are really a good candidate for a UKR nowadays, because we have no treatment for the root tear as such at this age, where there's a degenerative tear. So classic indication by Cousin and Scott, age less than 60 years, which is no more realized, is as good. Weight, low demand patient, anteromedial OA, range more than 90 degrees, flexion contraction less than 10, and deformity less than 15 degrees. Now, few of them are still with the test of time, which is a range has to be good. A flexion contraction cannot be more than 10 degrees. I would say 0 almost. Correctable deformity, less than 10 degrees is a good one, 15 is slightly more. So, most modern indication, which is Oxford criteria, age is not important because we are living in young and old both. BMI is not an absolute contraindication, but I think today my cutoff is around 34, not more than that. High activity level acceptable. We can't allow the patient to jump, of course. Isolated medial OA, bone on bone, intact lateral compartment, functional ACL, and correctable varus deformity. I think that's the most important part. Radiological indications, medial bone on bone arthritis, preserved lateral joint space, and minimum PF arthritis. Contraindication, active infection, of course, we won't do inflammatory arthritis. Make sure you check the CRP, anti-CCP and everything beforehand. More deformities, you can't really go for those things, and gross instability. BMI more than 40, I won't dare to do that. Severe patellofemoral arthritis, I won't ever talk about it. And ACL deficiency, I'll be very cautious and use a fixed bearing rather than a mobile bearing in case someone want to do it. So let's start with this case with 60-year-old female, BMI 29, middle compartment OA with varus deformity, ASA grade 2, no inflammatory arthritis. That's an X-ray which shows a medial OA, which is correctable on a valgus stress view. And of course, here there's no PFJ, but PFJ was normal. Pin placement for a Velis is slightly more horizontal than the normal. And here I'll share a video where we start with the registration process. Here, once we get a machine, I'm sure Vinay will show it better that with the, we mark the anterior point, then we mark the femoral point with the placement, pin placement point, then the medial malleolus, of course, the lateral malleolus. Next comes the lateral malleolus. Then we give a central point, which is the center of tibia. It will go on its own speed, I think, slightly. Is it not going on? Yeah, the central axis point of the tibia. Here we have to explore slightly more just to make sure we give the tibial, the femoral point as well. The axis point, here we go for a central axis, then the femoral axis point. These are the points which the computer asks for to give a hip rotation to get the axis of the hip, knee and ankle together. Okay, then we go for a flexion where we have to have a deflection to a full extension, and we get this graph which is once with blue line, then comes the tibial morphing. Mapping of tibia, this is the line where we have the ACL and PCL origin here. Then we start morphing the tibia, and the tibia is mapped very well. We have to get the most medial point, the most anterior margin point, and the medial point where it is marked by the and this you can get a surface marking of the whole tibia. With this software, we got something like a complete, here you can check the surface points are good. Here all the surfaces are green. That means the morphing is really good, and we got a good model which works very well for the tibia. Now then we go for a tibia. This most important point is the entry point, where in extension you mark this point that the implant should not go beyond this point. If it goes beyond this point, it can cause a patellofemoral tracking issues. Then we mark the tibia, and we get a tibial points here, where we get a tibial posterior point, distal point, and the most posterior point, where we get the complete topography of the femur. This is something like what we have seen in the other computers, where we have to have the complete morphing of the tibia and femur. But that gives more accurate assessment of the femur. Here again we check the femur. We have to get a point which is right. And then we check the whole femur. All green means the whole femur is very well in position, in right perfect things, and then we get a initial axis point. So, sorry, my mistake. So initial point was showing 10 degrees of varus. We target is around 6 degrees of varus. We can't correct more than 50%. So ideally you should target 50% of the correction of the joint. Now that's where we get the graph. Now if you see here, it's a, can you have pointer please? Pointer please, any pointer? Thank you. Now if you see here, it shows me a tibia planning. This is a planning done by the computer initially. 6.5 millimeter of tibia, because 7 millimeter is the size of the implant. This is the size which fits very well in both the planes, and the slope around 7 degrees. But if you see here, this extension gap of 7.5 millimeter, flexion is tight with a 5.5 millimeter, and we want a target of around 6 millimeter, 6 degree varus. So on the femur, it shows 6.5 degree of femoral cut, distal cut. It shows the axis around this point, but we can change all these things, and the 7.5 posterior cut of the distal of the posterior femur. So what I do, we do plan. This is the most important screen where we plan the whole thing. What I did is we have maintained 6.5 as the maximum tibial cut with a 0.5 degree of varus. We change the size to make sure the size fits very well, the middle point and anterior point, so the tibial base plate is fitting very well on this surface, and you can have a 7 degree slope. We don't change the slope much. Rarely we change to 8 degrees, but beyond that it's not required. It's not right as well. 7 degree slope. This is the 0.5 varus, 6.5 is the femur tibial cut. On the femoral side, because it was tight and hyperextending slightly, we cut distal femur less, 0.5 less. Then we can shift this femur to the right axis to make sure that we fit the proper size and the contour of the femur, and we can shift here by 3.5 millimeters just to make sure we are getting from here to here. And since we want to increase the flexion gap, we cut more 0.5 millimeter more of the distal femur, posterior femur, to make sure we get a gap which is balanced right, like 6.5 and 7 millimeters. So with this balancing we have done beforehand, now we know if we cut all these things, most probably we'll get something like that. So the computer accuracy, robotic accuracy will give us understanding where to fit the femur, whether the femur is fitting well or not, how much will be the flexion extension gap, and we can plan this. Once you plan this with the robotics, I think that surgery is more or less done. I think we just take a proper cut of the tibia and the femur along with and what we get at the end of it is something like, again, you can see a 6 degree varus, 4 degree hyperextension, but if you see the balance, the axis, the balancing of the medial and lateral medial collateral, both flexion extension is equally good, and we get a perfect balanced graph with such a accuracy. Now if you see the other side of the same patient, we had 9-degree varus, and we wanted target 6.5, around 5 of the, something like that, 5 degree, 50% correction. Again, here you can see the computer gave us 7 millimeters, this size 7 degrees. Here the balance was reasonably good in flexion extension, and here 6.5, again, it was going slightly more medial lateral. So here we thought 7.5 is okay. So what we did, we kept the same thing on the tibia. On the femur, because of hyperextension, we cut less distal femur. We didn't change much of a 7.5. Of course, we shifted the femur on this side, and the gap balancing was good. 6.5 in extension, 7.5 in flexion, and a actual target of 6 degrees. So once we plan these things, the saw comes in the plane. We just have to get the tibia and the femur, and it's a saw here. We have the boundaries. So the saw will not cut beyond this particular things. So there's no signs of no issue with the extra cut in the univallis. In other vallis, there's no, in the normal TKR, there's no boundaries, so we can, haptic boundaries not there. Here, we have a haptic boundaries in a UKR, and we can cut the right things, the TKR here, with the UKR. So again, here we got a 5-degree varus with the post-op picture, 5-degree varus, 2-degree extension. Again, the balance is good with no major issues with the balancing, mediolateral balancing. And here's the post-op X-ray, which looks perfectly well in terms of the placement of the component, the femoral rotation, and the post-op X-ray. So overall, with the VELIS, I think with the robotic, there's not much apart from the planning part. And I think the most important is to get the points right, plan the things right, and you get a picture like this. I'll show you one more X-ray, which is around 3 months post-op. Again, robotic TKR, UKR here. You can see a reproducibility of all the pictures. Overall, it looks perfectly well, and you can reproduce the whole thing again and again with a UKR. Post-op, 3 months, again, one more X-ray of a patient, where you can make out the component placement, the position, the sizing. I think the important is the tibial sizing here is very well marked properly. There's no overhanging medial or lateral posterior tibia, and the femoral rotation is very well marked with the robot. So what does the robotic TKR, UKR does? It gives very reproducible surgery, a perfect execution of what we plan, proper implant positioning, so though there is no overhang of the tibia, which is many times seen occasionally in an inexperienced hand, I can say that way. Perfect femoral rotation. Here, the computer gives you a femoral rotation, what is to be put in. So you just mark the point, the computer gives you a point, you just drill that, and it's all done. I think the live surgery will show all of that. And of course, avoid a lot of complications. Of course, the robotic cannot avoid infections and fractures, which can happen because of inadvertent either putting the wrong things wrong way, and I think excessive hammering of the implant. So those complications, but avoid complications like malpositioning. And it gives a confidence to the surgeon that he can reproduce the surgery again and again the same time. So indications are standard. I don't extend indication because I'm primarily a TKR surgeon who's doing UKR, and extended indication can give me a bad name sometimes because if you exceed the indication, patient doesn't do well, he'll spoil your other 50 patients. So make sure you don't extend the indications without reason. Of course, UKR has a place, but it has a limited place in our practice. We'll, of course, discuss in the panel discussion. And that's what the robotic UKR looks like. Thank you.
Thank you, sir. It was a very enlightening lecture about the robotic knee and this. Sir, we'd like you to have a seat at the dais. So after this, we'll be calling upon Mandovra sir, Dr. Hemant Mandovra sir, for his lecture on the conventional instrumentation techniques.
My talk should be back to back again?
You can do it.
So, Dr. Unmesh has set the ball rolling. He has taken back-to-back 2 talks. That leaves my talks also back-to-back. I thank you, Unmesh, for this. So, we will be talking on uni only, but there will be a slight difference in the thought process, and both the thought processes are good. So let us start with the conventional. Okay, so I'll be speaking about the conventional instrumentation in Unini. Before I start, I would just like to tell when we started doing unis, it was told that for if you want to sort of go through the ladder of the learning curve, you should have at least an experience of 25 cases of uni. Then you understand the intricacies and small problems of the uni. So I have no disclosures, but whatever I'll speak would be straight from my heart. It will be sounding philosophical, but it's backed by scientific evidence. And this is by no means a debate between a conventional and a robotic, so don't take it that way. After the advent of microplasty phase 4, with the latest generation instruments, the people who have seen and they are using it, the learning curve also has reduced. So nowadays, we say that if a surgeon learns to do 5 to 10 cases of uni with the microplasty instrumentation, he has already climbed up the learning curve and he now understands everything. And we get more predictable good results, even with the conventional techniques. And why is it so? Because they have worked very hard on the instrumentation. Each and every point that Dr. Unmesh told that a computer is going to say you on the screen has been taken care with the instrumentation. So the design is very simple. It is reproducible. Obviously, there are no change in the indications, but there are 1 or 2 game changers that have sort of changed the entire scenario. I'll go through them. So one is the milling concept. So when we mill the distal femur, we create sort of a ball. And a ball and socket joint, you know, in hip it works. So the range of in hip is inclination from 45 to 50 or 40 to 50. Version can be 15 to 25. So there is a lot of range. So you don't need to be really accurate to 1 millimeter. However, having said that, this instrumentation takes care that you are sub-millimeter perfect. So what are the tricks and tips in conventional? The patient position differs from a standard TKR. It is in a hanging leg position that we do. Obviously, there are people who do in the standard TKR position also. But for microplasty, a hanging leg position is preferable. Tibial cut is the key. If you get a proper tibial cut, then 80% of your job is over. There is hardly any medial release that we do. So we are not bothered about whether to correct that varus, because that varus is correctable. So when we see the X-rays and we decide on a uni, we know that after our implantation, the varus is going to be there of 5 degrees, which a computer will tell on the screen. We usually balance the knee in 90 and 0 degree in conventional TKR. But in uni or in Oxford, we take the extension in 20 degrees of flexion. The intramedullary entry point is also different from the standard TKR, which we'll be showing. And we have to understand just the simple maths of spigots. So Dr. Unmesh slightly confused me with that 7.5, 6.5 on extension flexion. But here we just need a maths of spigots. So it is 2 minus 0 is equal to 2, 5 minus 2 is equal to 3, that is what. So conventional, you don't need the computer to tell you the maths. So I'll also go through a 62-year-old female, same BMI and all non-inflammatory. And these are the X-rays that are needed. A standard AP view, a left AP valgus, a true lateral, and a skyline. So nowadays, what we recommend is we should write a true lateral. So next time you go and see your X-rays, 8 out of those 10 times you will not have a true lateral. So we are not seeing exactly what we really want to see. This is the tibial biscuit that comes out every now and then. So there is standard anteromedial defect. The posterior cartilage is always intact when you take the biscuit out. So just running through some steps, this is the incision only, a very small incision with the microplasty. So it is almost 50% of the traditional TKR incision that we take. And we do a quadriceps sparing arthrotomy. So we don't touch even sort of a subvastus, but a quadriceps sparing. So this is the exposure, and believe me that when I operate, even my second assistant cannot see. So it is very difficult for me to show in the camera. However, we have tried to show you. So we expose it, we do an arthrotomy, we release the osteophytes. Obviously, we check for the intactness of the ACL. It's a good idea to release the osteophytes on the medial side as well, because there are some tiny osteophytes which will hamper it. Then we size it with our spoons. It's a simple calculation depending on the height of the patient. What size of implant are you going to use? Having said that, with conventional techniques, you have a chance of going one size higher or one size lower depending on the case. So this is the jig that we put. We are not bothered about the ankle, we are not bothered about the hip, because we are just seeing the tibia, and this is the standard angle that we have. This is a fixed angle. This will cut in the same line. So we mark the vertical cut. It has to be just at the footprint of the ACL, and the bigger the tibia, the higher size is better. So with this oscillating saw, we take the first cut, that is the vertical cut, and the saw is meant for that particular size, so it cannot go posterior. It's a fear that it might go to the neurovascular structures, but it does not go that way. And every time we take it, then we take the horizontal cut. Again, Dr. Unmesh was telling about the haptic boundaries. What I do is I keep that vertical saw blade over there, and my boundary is created. And the moment we take the horizontal cut, the tibial biscuit jumps. After we get the tibial biscuit, we see that it's an anteromedial osteoarthritis. The posterior cartilage is intact. This is the biscuit that will come always. We are very happy. We can size it with the opposite side tibial cutting instrument. And it comes with a size of AA, A, B, C, D, and E. So with this, 80% of the surgery is done. Now, for the femoral preparation, there is a slight difference. We don't take the insertion at the summit of the notch. We take it on the medial side, 1 centimeter above, and we put a small pilot hole. And this is again a game changer. This is the link joint for this. So this takes care of the entire thing. And this is how it is put like this. So this is the right side. But this is the real video. So what I'm doing is I'm just putting a hole. I'm just enlarging the hole here. And the rod also goes very thin, and it's an intramedullary, just an indicator of where my position should be. And it goes freely with the hand. It should not be hammered. So once it goes inside, then we take the femoral cutting guide. We mark this femur from the medial to the lateral side, and we mark the central 1/3 of the femur with the cautery. The idea is that both the peg holes of the femoral implant should be centered properly. So this is the femoral cutting guide, and this is again a very good instrument, that is the link joint. It links properly so that the femoral distal cutting joint sits very nicely on that. So once we are sure that we have put the instruments right, then we just drill both the peg holes. So the first peg hole is 4 mm, the second peg hole, the lower one, is the 6.5 mm hole. Then we just create a round hole on the distal femur with the spigot, zero spigot. We want to create a sort of a sphere over there. Once we do that, now we take the distal femoral cutting jig for the posterior cut and we create the flexion gap first. So I am cutting the posterior part of the distal femur at this moment. This is done in 90 degrees of flexion so that we are creating the flexion gap first. This is again contrary to what we do in a total knee replacement, where we do an extension gap first and then match it with the flexion gap. In this, we do a flexion gap first and the extension gap is matched accordingly. We can see that the size of the femoral implant posterior is matching with the femoral cut that we have taken. So once we do that, we put a trial prosthesis inside of the femur, we put a trial prosthesis of the tibia inside, we take the rod out and start doing what is known as the spoon feeler gauge. So we want to feel the flexion gap. So once we take this out, with this feeler gauge, this black one, I'm just trying to put whether a 3 mm or a 4 mm is a real fit. And it's a very standard technique that you should use your index finger and thumb to go inside. It's a very standard teaching technique. Once we have seen the flexion gap, now we take the position to 20 degrees of flexion and now we see the extension gap. So my flexion gap was 3 and my extension gap is 1. So you don't need much of heroics to see whether you want to go how much deep to the distal femur. 3 minus 1 is equal to 2. So you will take a 2 millimeter spigot and then mill the distal femur and you will get the balanced extension and flexion gap. So we are again now sizing the tibia to confirm whether this tibia will fit the best, and then we'll create a keel for the final tibial implant over there. And then we put the implants and then again do a trial reduction. And this trial reduction gives absolute stable feeling. So this is the final implant. Since it's a mobile bearing knee, you can see the meniscus moving with the extension flexion very nicely, and the entire continuity is with the distal femur. So it's sort of a ball and socket joint. It's very, very stable. And then the closure is done as per the routine. You can see it's a very, very small incision. So friends, every time we do a uni knee or an Oxford knee, there is a wide range of bone loss anteromedially. So a patient may come to you with this small ulcer with severe pain, and he can have this much of the anterior defect. But all the times the posterior cartilage is intact. So that's the beauty of the AMOA concept. When we do a post-operative X-ray assessment, since we are doing a conventional thing and it's a ball and socket, so it's said that malalignment of the femoral component up to 10 degrees is acceptable, and tibial component of up to 5 degrees of rotation is acceptable because it's a ball and socket and a mobile bearing joint. So if you do a rotation like this and if you take a proper rotation, this will be the X-ray that we see. And it is absolutely reproducible almost all the time. So every X-ray of our post-op looks like the same. So thank you for your patient listening. There is another talk, if the chair allows, then we can continue. Yeah, please, second talk. So this was talk for mostly for the technical aspect of the conventional unis that we do. But the talk that I'm going to speak on now, the topic, is more relevant for today's modern arthroplasty summit. So, are we underutilizing the unis? That is the question that we have to ask ourselves. So, a 68-year-old male comes to you. So, what is our diagnosis at this moment? Osteoarthritis knee, everybody? And what is the plan? Everybody either will go for an opulent gold or for a PFC or something else. So in our mind, we have already thought about doing a total knee for this patient. Well, I also thought the same way 10 years back, but my thought process has changed and I'll run through. So when we see an X-ray, the first thought that comes to mind is kal ek TKR karna hai apne ko. So my disclaimer is, there is no disclosure. Again, I will speak philosophical, but it has got scientific evidence. Because I have always believed in, pehle istemal kare, fir vishwas kare. So people, you know, me, my journey has been based on conservation. So I started like anybody else with doing PS and taking such a big box out from the PFC in those eras, sacrificing the PCL. And then I changed over way back in 2011 to conserving the PCL. And I call myself a CR surgeon. So during my first few years of arthroplasty, I always used to see my tibial biscuits. And they caught me thinking, यार defect तो इधर ही है, ये मैंने पूरा इसको काय को निकाला है. So the defect was only in the medial part, and for this we used to take the entire thing out. And when I saw on the table my cuts, before taking the cuts, I could see that the cartilage loss is only at this point. The lateral aspect was absolutely pristine. So I used to wonder whether this is the right procedure that we are doing. So had I been in the place of the patient, I would have damned the surgeon that he has done something extraordinary for this. So this was my thought process in those times. Thanks to this great teacher whom I met in 2015, I am really proud and privileged to share the same platform with him nowadays because I teach for Oxford knee courses. I have become a great fan of uni knees. Let us call it only uni. Let us not diverge into the bearings part. So there was an interesting study in those times when they said that the patient dissatisfaction and the presence of ACL, there is a strong correlation. So 20% of the patients were still dissatisfied after TKR. And there was a strong correlation between the intactness of the ACL. So they believed that majority of these patients, the ACL is intact, we are cutting the ACL, and we are doing either a CR or PS, and that is leading to the complications or the dissatisfaction. Dr. Unmesh has already talked about Cosin and Scott criteria. They were very stringent at that time for unis, age 60 years and above. So there was a lot of things that one used to see, and the surgeon was afraid that isme uni kare ki nahi kare. Still, in those era, people said that 5 to 30% of the TKR candidates are good candidates for uni if we follow the stringent Cosin and Scott's criteria. However, nowadays, we have broadened the Cosin and Scott's criteria, so it has sort of increased the number of unis. And I know some surgeons who almost do 50% of their practice is now changed into unis. We all know the benefits of partial knee. The normal ligamentous joint is saved, so we are not cutting the ACL, we are not cutting the PCL. Functional outcomes are far better than earlier, and UK, this everybody has to understand and experience. And since we are talking about younger and advanced demanding patients, we know that many of them are going to come for revisions later on. So the revision of a UK to a TKA is much better rather than a revision of a TKA to a revision TKA. Over the past decade, even the patient expectations have shifted. So the traditional focus was on the survivorship of the implant, the functional scores, and the pain relief, obviously. But nowadays, patient wants an absolute happy knee. He wants to do all the activities of daily living, including dancing, including slight jogging and everything, cycling, swimming, everything. So joint replacement has been connected to happiness rather than just pain relief and just survivorship. So after the phase 4 microplasty, sort of India really had a second look on the unis. We were lucky that we started that. And the learning curve has really reduced. We have got more predictable results. So what happens in the practice when we do a lot of joints, we see patients in a wide range from mild arthritis to severe arthritis. It is said that it takes almost 10 years from going from mild arthritis to a severe arthritis, tricompartmental arthritis. And majority of these patients can be saved. They are good for microplasty. So there are many myths and facts regarding uni. The first is it is not indicated in young and active patients. Well, it's a myth because it's very good for a young and active patient. When I'm talking about young and active patients, we are talking about the early 50s. The patients do come, Dr. Unmesh just mentioned about a posterior root tear in which there is a dicey situation whether we can repair the root. It's a degenerative root tear, it is not repairable. The patient is still in pain and uni gives a very good result for that. It's really difficult to diagnose. So when we do knee courses, uni knee courses, there is a standard question about diagnosis बड़ा difficult हो गया है कैसे मालूम पड़े कि uni है कि नहीं. So I will tell you that eyes will see only what the mind knows. So once we start reading about AMOA, then probably every case we find either it is an AMOA or a tricompartmental osteoarthritis. A standard concept is that it's a stopgap arrangement. The patient is 50, just get a uni, after 10 years we'll convert into a total knee. But Oxford knee has shown almost a good survivorship of more than 30 years now. And the implant is the same as it was in 90s when Dr. John Goodfellow and Dr. John O'Connor designed that implant. The instrumentation has changed, but the implant has remained the same. Again, it's not a debate, it's not a controversy. People are more moving towards a robotic total knee rather than a uni. What I would suggest is we should conserve as much knee as possible, if it is possible, rather than going for a total knee. Very restricted activity post-uni, no, it is not so. We have got many patients who are doing practically everything they want to do. Obviously, Dr. Unmesh said that jumping, active contact sports, these are to be avoided, but rest all the patients are really happy. So my patient present selection criteria, age is no restriction. So the youngest that I have operated is a 39-year-old female. The oldest that I have operated is a 91-year-old male. So age is no criteria. Correctable varus definitely, intact ACL, especially for mobile bearing joint. BMI, I have no particular cutoff. But obviously, if it is a very, very obese patient, I am also reluctant to do a uni in those patients. No lateral arthritis, and obviously it should be not inflammatory arthritis. So these are the selection criteria. And after this selection criteria, there is a paradigm shift in my experience also. So nowadays, what we say is, if we write on the paper, either it is a tri-compartmental ONE or ONE as such, or we write AMONE. And Dr. Unmesh also mentioned about bone on bone. So it's one of the criteria of doing a uni. So if it is full thickness cartilage loss on the medial compartment, then a uni is definitely the surgery of the choice. And it is backed by clinical, radiological and biochemical tests rather than an MRI or something else. It's a simple clinical and radiological test. So when we look at our own data, after doing almost more than 700 Oxfords, it forms about 1/3 of my arthroplasty practice at this moment. So I won't call myself a total knee surgeon who is doing uni. I call myself a knee surgeon who gives a tailor-made thing for the patient. If he is a candidate for uni, I am going to offer him a uni. If he is a candidate for total knee, I am going to offer him a total knee. Thanks to Ayushman, uni is still not in the code of Ayushman. So we have to do many patients who are good cases for uni, but they come under Ayushman category, so we have to do for a total knee. I have to cut that ACL, but there is no other option that we have left. So again, coming back to my first case, again a 69-year-old male. So based on this, I am not going to diagnose what is that. My standard X-rays are valgus stress view, true lateral, and a skyline view. And with this, I say now it's a bone-on-bone arthritis, AMOA, and I'm going to do this. And believe me, there was no bone here, but the posterior cartilage was still intact. So you just take a thin sliver out. At times there is no bone that you are cutting from this side, but the posterior cartilage is still intact. It's a traditional anteromedial osteoarthritis. So the take-home message, friends, is 20 to 40% of all arthroplasty that we are doing are AMOA. They are candidates for uni. There are excellent long-term survival now. Many papers have come and better patient satisfaction with all the unis. The partial knees is for all ages, so there is no age limit as such. It's not a time-buying procedure for total knees. And all arthroplasty surgeons should have the knowledge and skills towards learning for uni. Whether you do it or not, but you should have the knowledge. And this is the incision that we give traditional. It's a very minimal invasive surgery. So friends, now is the time to change. When you see this X-ray next in your outdoor, don't think of going for this, and at least have a thought process for going for this. So what I say is uni knee is partial to the knee but fair to the patients. Thank you so much. Thank you, Dr. Vinay and Mac, for having invited me. Thank you.
Thank you, Hemant sir. I would like you to come on the dais, and we'll have a good panel discussion regarding, I think now we have both the superheroes, one with the robot, one with the conventional. So now I think the panel discussion is a very important thing, which we should go ahead. Sir, Dr. Unesh Mahajan.
Next talk, panel discussion, UKR. So I think the last point is very important, as Dr. Mandava mentioned, that whether you do a uni or not, you should have panel discussion, UKR panel, last, yeah, that one. The knowledge is important. I think one should have a knowledge, because nowadays, I think the trend is now, it was a PS, now changed to CR. Now from CR, people are slightly changing towards uni more than expected before, because of the few things we'll go discuss. Few things repetition, I won't be very, I'll be very quick in terms of. So as we mentioned, all this we have seen again and again, and now this is the thing. But what is the algorithm? What is more? Do we all agree with this? That Dr. Hemant, ACL, what's your take on ACL on this one? Do you do people with mucoid degeneration? Because a lot of people will come in MRI as well and who have the mucoid degeneration. So what's your take on mucoid degeneration?
So my take is,
Yeah, you're audible.
if the ACL is functionally intact, even if it is mucoid degeneration, I would go for uni if it is meeting my other criteria. So what I take is standard 4 X-rays, AP weight bearing, AP valgus stress view, and I always rely on true lateral, because at times the true lateral is going to show me that defect on the medial tibia.
Yeah.
And there is a sort of a slope going ahead, which I know that the cartilage is intact on the posterior side.
I'll come for that. So all is good here, and you want a particular tracking something like this and not something like this, yeah? Okay. So why X-ray indications? As you mentioned, young patients are asking for more and more early wear and tear is happening. As we all as senior surgeons have seen, the pendulum has shifted from 60s to now 50s. Now in your OPD, a lot of patients with 45 and 50 with a gross middle OA, we don't know what to do with them because we are scared of putting a total knee as a age part. And we now, so there where I think the uni can be a bit of a handy procedure, very active patient. And now we have a good implant survival. So I think we have extended indications because of those things. So let's see what's the indication like. So if you see a X-ray like this, how many would go for a total knee here and how many on the both sides? I think the first indication for many people looking at this lateral gap and this lateral gap would be total. How many would do total here? Is just in the audience, if you just raise your hands. Total mostly, many of them total probably. Yeah. So let's do anyone from the panel here? Anyone for a uni apart from the first one?
So my criteria is again, I'll have to see all the
I
four
know,
X-rays.
I know, but still.
Yeah.
Okay.
So this looks to me a good case for uni in both the knees at this moment.
Okay. Now, but somehow my worry is sometimes, I don't know whether we should see lateral osteophytes are something to worry about, or this posterior small osteophyte, they're not nothing to worry, no? That's fine. And now that's a stress view, which shows a correctable varus here, and I think that's an indication for UKR. So, now the last week we've been to a uni conference, and the dictum was, every patient is a uni patient unless proved otherwise. That's a bit of a too much, I think that's a too much for me, but that's what they say. Every patient is a uni patient unless proved otherwise. But I think that's going too much of beyond the pendulum, you know, beyond the equator, I think. So that's, but I'll show you why. This post-op X-ray, because on lateral part, once we went in, we could see a lateral patellofemoral joint was not good at all. It was a grade 4 on the lateral side. So I did a total knee, though it was looking like I consented for uni. I went in, but when I realized there's a lot of osteophytes here, you can see a grade 4 patellofemoral, I was not very happy, so we did a total for him, and that's a CR knee. Of course, we all know. Now, here, any contraindication for you? What's the BMI cutoff for you?
So I don't, that is what I told, that BMI, there is no cutoff, but obviously if it is absolutely obese patient, then I'm not going to do an arthroplasty in that patient first. I'm going to say him to or her that you get a bariatric or you lose weight and then come over. Because even if I do a total knee, the patient will not be happy. So before getting embarked into the arthroplasty part, we'll have to take care of the BMI. Okay. But if it fits on the criteria of what I have said on the Cosinus Scott, then definitely we can do it. My cutoff is say 36, 37.
Yeah,
so
the consensus was 35 BMI in the last meeting with all the joint replacement surgeons. So most of them were total knee. But now, again here you can see grade 1, grade 2 changes here. But once I opened it inside, I could see this is very difficult to understand. The trochlear is not very good, and the patellofemoral medial side is completely gone. Lateral was somehow not so good. So that person I opened for a uni turned out to be this. Now, can I have opinion of the house where how many would go for a uni and how many go for total? Now, Dr. Mandava, I see
the house is biased, I know this.
No,
but having said that, if you really take the indications of what Dr. Chris Dodd says, and the Oxford people, they sort of teach, medial patellofemoral joint will always be all gone. The lateral patellofemoral joint will always have a grade 1 or 2 if it is a full thickness or a striations which are seen on the skyline view, then it's an absolute contraindication. Because once you make the length, whenever you do a uni, you understand that the moment we open the knee, the ACL is lax. But when we put the final joint, the ACL is absolutely tight and fully functional.
Okay.
So that takes care of the patellofemoral as well.
So here, if it's your patient, what do you do? Because see, my point to the audience is here. The trochlea was not looking good at all. Lateral trochlea was good. Lateral meniscus was good. But this particular area and the going towards the midline, something on this side. So, would you do?
See, for a beginner, I would say that don't hesitate to convert into a total knee. But at my situation, my conversions, when I have thought that I am going to do a uni, the conversion is almost less than 1%. So even in these cases, I definitely do a uni. if they match the criteria of ACL and everything.
Okay, but you are not worried about this trochlea groove not going looking good, no?
Not really, because preoperatively I have assessed that the patient had full flexion. There was no
Yeah.
patellofemoral pain. So the patient will not have any pain later on also. That is what I feel.
To be honest, my worry is that my practice is very well at the moment. I don't want to give unhappy UKR patient with a patellofemoral pain. And that's what, so I consented to start with the UKR. Patient was also okay. I went ahead and then because of the trochlea issues and not happy with the lateral part may come up with a painful TKR, UKR, I did a total knee on her, but the same thing. I was not very happy with the trochlea part and the lateral part going slightly grade 2, grade 3. And here, the point is when you have options of both, I don't want to take a chance with UKR sometimes because then I know that my patients are otherwise doing well. By not having a right patient, I might actually screw up my own good patient. So whether ACL matters, I think very well. ACL definitely you should do a UKR with a fixed bearing and not mobile bearing. Okay. How many times you have done a UKR with ACL? No. I think for beginners, you should not try ACL with UKR together. It's overbearing things and you should not be doing that. So standard X-rays, here's the stress X-ray, what you mentioned, 20 degrees flexion. I think that's the standard for UKR, yeah? Okay. So everyone who want to do a UKR should start teaching the radiographer that how they take an X-ray, and that's very important because you should take a proper X-ray. So if you see an interpretation of a stress X-ray, that's a standard non-rotated view. Again, it's a valgus. Again, you can see in 20 degrees opening up, and there's no signs of a lateral closure. The important part is not to have a lateral closure of the gap because that's where it shows lateral compartment is good. So what is right? You can see here, this is right, this is medial OA, this is right, medial OA, but it may not open up. So, and if you see that the lateral is crushing, we should not be doing that. So again, functional intact ACL, as Dr. Mandava mentioned very rightly, lateral X-ray is very important. We can see a erosion in the anteromedial part. Erosion going all the way is not the best way. I think, do you agree with this? Anything else you want to add on the X-ray by any chance?
No, I think the third one on the down, is still showing some elevation.
Yeah.
So I would not do a red cross.
Okay.
It's a plus minus for me at this moment.
That's fine. So you should have such an X-ray. And again, valgus stress view. See, when the lateral gap is closing, that means the lateral cartilage is gone. So that's the most important part is not the correctable varus, but even pressurizing on the lateral side is very important to know who should you operate. Okay, that's where. Now patellofemoral, this is very right. This is not so right, probably in my patient. Of course, this is gone. Now, here comes the picture. If you are a UKR, TKR surgeon, and your inclination to your UKR is 50-50, then you would not do this. Probably a convinced person who's very dogmatic about UKR would do that. But I'm not sure about it myself sometimes. If there's anything in doubt, I'll do a TKR. So implant choices. Now you have a mobile bearing, you have fixed bearing. So anyone has any inclination towards fixed bearing? Anyone did a UKR? No? Anyone in the audience does UKR? Fixed bearing? Okay. So what's the difference between mobile bearing and fixed bearing? Dr. Hemant, your choice. Why? Of course, you are now, since you are teacher for a mobile, you can't do but any doubts on that? Yeah.
So I don't see any difference in the implant choice. It's the instrumentation and the technique that is different. So if you are doing a fixed bearing, you have to understand something. There are some different steps that you have to do. And if you are doing a mobile bearing, you have to do something different. The only thing that I think is probably in an ACL deficient knee, in an elderly, if you want to go with a minimal invasive surgery, and you can get up with a fixed bearing.
Okay.
Mobile bearing is not going to work if the ACL is deficient.
I'll show you quickly the result of a survivorship. Revision rate remain higher than the TKR for sure. So in 15 years time, 15% revision rates for a UKR. Now that's where I would like to ask your opinion. In an Australian registry, 20 years follow-up, basically shows fixed bearing implant, the revision rate is 20-25%. Mobile bearing is more than the fixed bearing. Any reason you think of is the mobile bearing are not doing so well in the registry part?
So we had a discussion in the Oxford group once, and we had people who have done more than 10,000 joints. It was said that when you see the post-op of a TKR having some problem, you are very reluctant to do a revision for that. But if somebody gets a patient who is having even a small problem with a uni, then he is very, very confident कि अरे इसको तो total कर दे ठीक हो जाएगा तो पहले ही दिन उसको कर देना चाहिए था. That is what happens. So the conversion of a uni to a total is very common when the patient has got any problem. But a conversion of a total to a revision is very difficult. The person then says कि अभी दवाई लो देखो करते हैं कुछ करते हैं. But for a uni, the surgeon is very, very sort of proactive in revising.
Someone told me last week that you should not touch a uni for any revision till 1 year. Is that true? Because they settle down in a year's time.
So there are patients who are having acute pain like a degenerative meniscal tear. If you don't see the sclerosis on the medial tibial part, then probably the patient will have a pain for 3 to 6 months. But if it's a chronic AMOA and if there is a sclerosis, then the patient absolutely forgets. So there is a term known as forgotten knee score. For an Oxford uni, the forgotten knee score is to the tune of 45 to 50% in the first month.
Okay, fair enough. So that's the revision rate. Oxford study survival rate 20 years is 91%. So quite good for Oxford's knees for their own things. And here you can see 22 years, 91% survival rate. Failure rate, bearing dislocation. Now for a uni, I think for a new people who started a uni, I think going for a fixed bearing is much better sometimes before you get enough confidence to put a bearing which is mobile like Oxford. Tibial fractures, malalignment, of course late progression of lateral compartment loosening and polywear. Now conversion is of course very easy. The point is here, if a patient comes to me and asks me, what's the success rate of uni to total, and if what happens, what's the duration you tell the patient about uni, life of uni, how much you tell the patients? Very honest opinion.
So I say that the survival rate of a total and well done uni is the same.
Is it? Okay. And anyone ask you guys कि survival of uni कितना है and total कितना है? Anyone? Uni? See, honestly, in my practice, I'll tell them around 10-15 years is a uni. But he asked me a total, I said 25 years is not a problem with the present generation implant. And that's where the patient says, "Fir sir, totally kar dalo." And a lot of people ask me, because see, the people in our area is not very, very affluent people. They are farmers, they are traders, they have a limited amount for most of the stuff. So they say, "Saab, ek hi baar pura kar do, taki baad mein wapas na aana jaye." Now that's where I want to ask your opinion, because you also get patients like us only. So how do you tell them that this will last your lifetime? You tell them.
I don't tell them that anything is going to last lifelong. So we are not going to give guarantee. What I am trying to say is कि साहब मैं तेरे को वही result दे सकता हूँ, तेरा जो natural घुटना है 75% वो बचा के.
Okay.
So what example I give you is the mobile phone. So when the screen guard of your mobile phone gets cracked, do you change the entire mobile or only the screen guard?
Okay, fair enough. Now, one thing patient always asks me, साहब बाजू वाला घुटना खराब होगा तो क्या करेंगे? मतलब the lateral part. And do you have any answer for that? So, because I say I can't guarantee that. I can say, okay, 10 years is good enough. But so that's those middle class patients where they are really short of money and they want only one procedure. They only ask these things, which are difficult to answer from me as well. Because though established surgeon, you have no answer for few things like a lateral खराब तो नहीं होगा, फिर उसका क्या करेंगे, फिर साहब उसका भी operation करेंगे क्या आप? So a lot of questions, and what else you said right, 20 to 30% can be a UKR patient, but only in my practice 5 to 7% patient gets a UKR, because most of patients don't want to get UKR done for the simple reason of fear factor of future, repeat surgery and other things. So that's where I think the UKR has an issue. So we'll stop with this and we are done with the things. Thank you so much. Thank you.
Because the anesthetists, our friends are quite um, quite disturbed because we are having these sessions here. So I would like to take a small interruption between the lecture. Dr. Pradeep sir will be coming after this surgery, and we'll be connecting live with the, or re-live with the OT for the demonstration of the UKR in the OT. Can we connect to Dr. Vinay sir? हाँ, ठीक.
हाँ सर, you are
यहाँ भी
live,
आएंगे.
sir.
हाथ देखो उनका. अजय हाथ देखो.
Hello. Vinay sir, are we audible here? Hello. Vinay sir, are we audible?
Yes, yes, Arjun, I can hear you. Can you hear me?
Yeah, sir. You are on live here.
Okay, so we are just inflating the tourniquet. Can you show the X-ray meanwhile? X-ray. क्या है? सही है? Inflate कर दो. Yeah. So this is a 60-year-old male. He is having pain in the left knee, typically anteromedial aspect, and since last 2 years, and is not responding to the conservative treatments. He do not have any pain in the anterior compartment of the knee or into the lateral side. So we are considering it a straightforward case for the UKR. We are planning to do unicondylar knee replacement in such case, in this case, with Wellis robotic system. Yeah. टूर्निकेट हो गया क्या? Okay. So आप लोग हट जाओ, मेरे को दिखाना पड़ेगा ये पूरा. Can you show this robotic machine here front? ये मशीन दिखा दीजिए. You are yes. ऊपर का दिखाओ, जूम आउट करके. जूम आउट. सर आप अभी आपका काम हो गया. और जूम आउट करो, पूरा मशीन दिखाइए. जूम आउट. सर आपका नाम बता दो मेरे को. संदीप जी, ये ऊपर का कैमरा सैटेलाइट यूनिट दिखाइए. ये ऊपर ये कैमरा. हाँ.
Sir, we can
So
see that.
this is a camera part of the robotic system, and below that is a screen in which we will see. This is the camera which captures the signals from the arrays which we fix onto the patient. Okay, टूनिके हो गया? ठीक है. अब तुम्हारा भी काम हो गया. सिर्फ ये लाइव वाले रहेंगे. अब कैमरामैन चल. हाँ. So हटो कुणाल. This is the robotic arm, this saw, and you can see this is the array. This array is fixed onto the robot. It has reflectory markers which reflect the signals. Okay. क्या हो रहा है टूर्निकेट में? क्या हो रहा है? चेक नहीं किया था क्या?
Vinay sir? Hello? Dr. Vinay sir? Uh, we'll continue with the lecture part because of some technical default. I would like to call upon Pradeep Chaudhary sir for his lecture on fixed bearing and mobile bearing. Uni.
Good afternoon, good morning rather, everyone. And thank you Vinay and the MAC team for allowing me to present. I'll talk about mobile versus fixed bearing on unicondylar and knee replacement, though Dr. Mahajan has talked a little bit about that. So UKR is a preserved cruciate ligament and bone stock. It lower morbidity and faster recovery than a total knee. Two principal bearing concepts are there, a mobile and a fixed bearing. The design difference is there that the insert free to translate and rotate in a mobile bearing aim to improve conformity and reduce wear and requires good ligament balance. While fixed bearing, the insert is fixed to the tibial tray, there is no motion, it provides increased stability, technically it is less demanding. The goal of a surgery is to optimize contact mechanism while maintaining the stability. The biomechanics is that the mobile bearing, a larger congruent contact area, lower contact stress and self-alignment. So there is a lower stress over the poly, while in fixed bearing, a less bearing mobility, easier balancing, and there is a higher stress over the poly. Both depend on the precise implant positioning, optimizing alignment and soft tissue balance, and good technique lead to durable outcome in both. Both designs are aimed to optimize contact mechanism while maintaining stability. The advantages of mobile bearing is it reduces polyethylene wear, improve conformity, potentially better kinematics, useful in younger active patient where technique is optimal. Mobile bearing design aim to contribute durability with more natural knee kinematics for active well-selected patients. While the fixed bearing is a simple surgical technique, lower risk of bearing dislocation, less sensitive to ligament balancing, and it is widely applicable. So a fixed bearing is a reliable, stable choice with proven outcome and ease of use. The disadvantages is that in mobile bearing, a risk of a bearing dislocation, technically it's a demanding and it is sensitive to malalignment. While fixed bearing, there is a high contact stress, so high chances of polywear. Edge loading is malposition, so careful patient selection, accurate implant positioning, and proper technique is key to minimizing this risk. The clinical outcomes both provide excellent pain relief and function. Survivorship is more than 90% 10 years in experienced hand. No consistent superiority of PROMs in model studies. The modern UKR, mobile or fixed, deliver reliable, durable, and predictable results when performed with precision. Complications are, for mobile bearing, there is a dislocation or instability, while in polyurethane wear and loosening are quite complication. Early recognition, meticulous technique and appropriate patient selection are key to minimizing this complication and ensuring long-term results. What the evidence says, the multiple meta-analysis and many controlled randomized trials say similar outcome. Survives with more than 90% 10-year in experience, and what really matters is surgeon's experience and your patient selection. The patient selection is, as Dr. Mahajan has already talked about, intact ACL and collateral ligament, isolated compartment arthritis, correctable deformities, good range of motion and function. You should avoid surgeries in inflammatory arthritis or severe instability. So careful patient selection is key to achieving excellent outcome with unicondylar knee orthoplasty. When you see the comparison table, the wear and slightly contracted stage is low wear in a mobile bearing while higher in a fixed bearing. Both design have excellent outcome when useful in appropriately selected patient by experienced surgeons. The clinical outcome and long-term survivorship, most randomized trials show similar pain relief and function. Patient-reported outcome are largely comparable. No consistent superiority to mobile bearing over fixed bearing. When we come to the survivorship and revision, long-term survivorship is excellent in both design. Registry data generally shows no major difference in revision rates. Implant positioning remaining more important than the bearing type. Range of motion and kinematics, some studies demonstrate a small kinematic advantage of mobile bearing, while differentiates rarely translate into a meaningful clinical benefit when we see the clinical outcome. Range of motion outcome are generally similar in both designs. These are evidence summaries that it is roughly, it's there, the cost is higher of mobile bearing and spin out risk is there, while polywear is more common with fixed bearing. Mobile bearing provides theoretical biomechanical advantage. Clinical superiority has not been demonstrated. Survivorship is excellent in both design. Surgical technique always outweighs bearing choice. Modern polyethylene has narrowed any wear advantages. So take home, both designs are excellent if properly indicated. Surgical technique always outweighs implant design. Choice of implant based on experience, anatomy, and patient factor. The best outcome come from a right indication, meticulous technique, and patient-centered decision making. Thank you very much for your patient hearing.
So we'll get back to the surgery. Can we connect with the OT? Hello. Dr. Vinay sir, we are live, re-live with the surgery.
क्या knife है यार?
Dr. Vinay sir, can you hear us?
इस side हो, यहाँ. Hello,
Yes sir.
can you hear me?
Yes sir.
Yeah.
Are we audible here?
Yeah, yeah.
Okay.
So I'm just giving a medial parapatellar incision. Can you see this? Can you appreciate this cartilage loss, full thickness cartilage loss here? I can't hear anything from the auditorium.
Hello.
Hello, Arjun?
Yes sir, we are.
Can you see and
Yes, yes.
hear?
Yes, we are very much, you are very visible very clearly. We can see almost.
I cannot hear. Volume बढ़ाओ ना यहाँ से.
Sir, we can see and it's very clearly demonstrating.
Okay.
Actually, we can see inside the joint also.
You can see the full thickness region
Yes.
in the medial femoral condyle.
Yes,
Yeah?
yes, yes, clearly.
Now can you see this ACL, intact ACL? Light चाहिए यहाँ पे, वहाँ से light डालो.
I think that retractor, cautery wire also is coming. Yeah.
Can you see the ACL?
Yes, yes, we can see the base now.
This is the ACL. And if you can see this completely normal lateral compartment. Here.
Yes, yes, now ACL is quite visible.
Lateral side,
Yes,
this is normal. Lateral compartment is normal. Only medial compartment is involved. And you can see a full thickness lesion in the femur as well as in the tibia.
yes, yes. And even the osteophytes are visible.
Yeah, osteophytes are also visible, which was not visible on the X-ray much. By looking the X-ray, it seems like I'm just releasing onto the medial side.
So what is the feel of the patellofemoral joint?
Okay, so patellofemoral joint, I can show you by slight eversion. Can you give me a towel clip? There are patellofemoral arthritic changes, but not much. And the trochlear groove in the femur is absolutely fine,
Yes.
but under surface of the patella
Yes.
has some lesions.
Okay.
Okay,
we can
so
see.
I'll do this osteophyte. I'll remove the osteophytes and will do some patelloplasty at the end.
Right.
Rettingle. I'll clear all those things which come on the way here. Anterior horn of the medial meniscus. There is a small osteophyte at the base of the ACL. Okay.
I think trochlea looking normal, so that's a good, healthy trochlea gives a confidence of good PFJ, hopefully.
Yeah, trochlear surface is completely all right. So in Wellis, what you need to remove all the osteophytes in advance. Give me nibbler. ज़्यादा नहीं है, इसको ज़्यादा नहीं, इसको ज़्यादा. छोटा निबलर. I'll remove the part of the medial meniscus right now. Okay, give me a spike. छोड़ उसको. निबलर छोटा वाला. निबलर. कैमरे को सही करो. So like TKR, here also we need to balance the joint properly and not to overstuff the middle compartment. These are the two things which we should consider here. Okay. So now once I have removed all the osteophytes from the medial femoral condyle here as well as the tibial condyle. Now I will put the pins for registration. Yeah, femoral pin. Give me knife, skin knife. Just make a little longer incision. Pins. एक वो भी दे दो मुझे. Array. So since the space is very limited over here in the UKR cases, you should fix your array properly, and they should be directed properly so that it doesn't come on the way of saw. हटाओ उसको.
Vinay, any fixed position for putting pins here or any landmarks?
No, not the fixed position, but the position should be in such a way that these things do not come in the way of their cuts. थोड़ा सा zoom out करना ताकि ये पूरा array भी दिखे. Zoom out the top,
They are
this
slightly
one.
more horizontal,
इसको
right?
zoom out करो उसको.
They are slightly more horizontal compared to the standard pins. Which are
Zoom out करो इसको. Yeah. More. Yes. So the array is fixed properly so that it doesn't come in the way of the saw. थोड़ा zoom out करके दिखाना क्योंकि otherwise it will not be clear. Second thing, yeah. For the tibial side, remove it. Tibial array are not such a problem because you take it extra incisional. That is outside the incision. So here the arrays are fixed in the metaphyseal region, in the tibia as well as in the femur. Pin दो. लाओ ये खोल दो. तुमको हटना पड़ेगा वहाँ से. Now can you show the camera out, robotic screen output also? Both together. PIP, yes. ऊपर कर. टीबिया नहीं दिख रहा, थोड़ा टर्न करो.
Sir, please describe also what the plan
ठीक
is
से ना.
going
Yeah. So I'm just preparing for things for registration. Now the camera is set in such a way that it captures all. इससे नहीं हट रहा है, तुम्हारा वो टीबिया नहीं देख पा रहा है. उसको ठीक से करना है इधर पे. Yeah. So now कहाँ देखो ना, एरे सही है टीबिया का. Change the array tibial. यार बहन. at present the screen you can see the T is marked in the red, so it means it is not able to visualize the tibial array. तुमको बोला था नए लाना है. Wait. Yeah. Okay. So now our arrays are fixed properly and these are visible to the system properly. That's why the camera position has reached the target, and now we can go ahead. This. I have a blue paddle, so I can start with that. So now it is asking for the registration of the fixed point. Give me a pin, Panchu, and a hammer. I have to mark two fixed points onto the tibia and the femur. Hammer, marking pen. These points should be in a position which does not go in your cuts. Yeah.
Sir, what is the concept of this new point?
So in between in the surgery when we'll start taking cuts, we'll just interchange कर. घटिया सेट निकाल के दिया तुम लोगों ने. If during surgery if the array moves by any issue, then we can get check of it, and we will know that if the arrays are moved, then the cuts will going to change accordingly. Now we are starting the registration, taking the medial malleolar most prominent point. The lateral malleus most prominent point. Then the center point on the tibia, proximal tibia. This is at the base of the ACL. This is a tibial sagittal axis. So this is up to the PCL. According to this, the slope plane will be decided. Then we'll take the center point on the distal femur to get the axis. Now we'll take the hip center, and now we'll acquire the range of motion. So now the points on the tibial resection reference point on the medial tibial plateau. From this point we will be knowing that how much deep we are going into the tibia. This is the anterior point on the tibia. Now the most medial point on the tibia. Now the tibial implant border onto the medial side, onto the lateral side. This is at the level of medial tibial spine. Okay, now I'll acquire the tibial surface so that we do create. यहाँ से नहीं आएगा. Go there. The air. Now I am doing the morphing on the bone. से स्पाइक लगाना चाहिए. As many as points we can collect, we should collect it to get the better surface of the tibia and to achieve more accurate anatomy of the tibia. Okay. So we'll check our checkpoints. Yeah. Now registration for the femur. Anterior tight point so that the implant can be identified, and the anterior margin of the implant. So this is basically the tight point onto the femur, and then we have to acquire the spike. दो मुझे दो spike. I'll reflect the patella here and here. नहीं कुणाल लाइट निशन कुणाल वो कैमरा डिस्टर्ब हो रहा. या थैंक यू.
So while morphing, you have to completely get the shade over that part, or
थोड़ा सा वॉल्यूम बढ़ा उसका. So we should collect more and more points onto the surface so that we get better information and better anatomy of the implant of the patient's bone there. If we leave small area which are not covered, that is also fine, that is not an issue. So I think these are more than enough points we have captured. The anterior point, posteriormost point, and this is the distal surface. Okay. Now we will take the initial hip, knee, ankle axis. It's around 5 to 6 degree of varus, 5.5. Press कर दो. दबाना ठीक से. क्रॉस के बाजू में. हाँ. हाँ दबाओ. So this is initial 4.5 degree of varus, and now we can decide how much varus we want to give. I will just keep it around 1.5 to 2 degree, 1 degree. This is also okay. I don't want to go neutral or in the valgus, so that our lateral compartment is overstuffed or affected. So you can see the range. It is approximately 6 millimeter flexion gap in the flexion, as well as whereas 6.5 in the extension. टीबिया का मुझे फिर से एरे दिख नहीं रहा है, इसलिए चेंज करो, नया बुलाओ. Okay, so now I'll plan the cuts after this. So registration is complete. Initial equivalence graft we have achieved. we have decided the final alignment which we want to keep at around 1 degree of the varus, and then we'll go ahead. Okay. So now I need at least 8 millimeter of the gaps on the medial, on the flexion and in the extension. So the tibia which is there 4 millimeter, I'll put it down distal. Thoda on. Yeah, bas. So around 6 mm tibia cut, I'll take the cuts and I'll get the flexion and extension gap of approximately 8.5 millimeter. And the femoral size here, it is coming at 1, which looks little smaller for me. So can you increase this size? 2, 1 more size, yeah, 3. So now you just हाँ ठीक है, इसको ओके करो, ऊपर जाओ, स्क्रीन पे प्रेस करो, हाँ. Now 6 को ऊपर ले जाओ, फीमर को प्रॉक्सिमल, और थोड़ा और, या 4, थोड़ा और नीचे कर लो. Yeah, so this is acceptable. 7 degree in the extension and 8 degree, 7 mm in extension and 8 in the flexion. I can कहाँ किसके लिए रखे थे ये, किसके लिए रखे थे संभाल के. Okay, so the posterior slope which we have kept here is 7 mm, 7 degree, which is good. Important thing is you can see the line which is going through the implant in the center pictures. That's orange line that indicates the travel of implant over one another. And if it is in the center, then it's fine, perfectly all right. We can change many more things. We can shift the component anteriorly and see whether it is affecting or not. If we shift the component slightly anterior, then the flexion gap will increase, and if we shift it posteriorly, flexion gap will decrease. So accordingly, if we see here, our planned HK axis was 1 degree of varus. Since we have cut more of the tibia, it is 2.5 degree of varus. So if we need to correct it, we can put an insert of 7 from 7 mm to 8 mm, and it will create more valgus in that case. But this is what I am extremely happy, and will go ahead with this. So once this plan is confirmed, then the planning, then we need to execute our plan, and just going ahead. Yeah. So that point which we have taken initially now comes into the play. We have to see whether our arrays are moved or not before taking cut. Give me the array. Yeah. Okay. So if we have kept our pointer onto the bone at that point, it is okay to go ahead. Okay. Now give me spikes. One. I have some special spikes here which can go femur side. और जाओ हाँ. पर अभी प्लांट पे आ रहे हो, हटो वापस आओ, leave it. छोड़ दो हाँ. Now I have to press the blue button, so this robo will come into the plane which we need to take. Now hold this, Kunal. तुम ऐसे ही पकड़ लो, कहीं नहीं जाना. Yeah, spike. Okay. Can you see this? I think it's too bright onto the screen. It's too bright. ना ये दिक्कत दे रहा है, सेट जाओ और उधर हाँ. So my first cut is complete. Now I'll take a vertical cut with a reciprocating saw. Give me the pointer. I'll check how much distal I have just taken 0.5 to 0 mm distally and medially, vertical cut I have taken it properly, so that this is indicating a green line over here. Okay, so my cuts are verified. Now I'll take out this proximal cut. Give me a freehand saw. Small amount of bone is left here. I'll just remove it. Give me the curate. Yeah, it's out. वो देखो दूसरा वाला बोन का पीस. Can you show this? Oh भैया, इसको दिखाओ. Okay, so the complete bone is removed from anterior to posterior. You can see here. Okay. Leave it. There are a few osteophytes on the back. Then nibbler. Right angle spike though. इससे कहाँ होता है यार? ये लेना चाहिए. Okay. Now give me the trial. I'll put the trial and assess. Okay. So now after taking this cut, the gaps are coming proper, and it's about 2 degree of the varus which we have got. Okay. Next.
It looks good, yeah.
Yeah. Sorry.
It's good, I said. Looking good.
Yeah. Thank you. So After this also, if we want to change, make any change, we can do those changes right now, but I think everything is fine over here at this moment. So I'll go ahead with the cuts which we have decided. Okay, na? So before taking any cut, system asks for the verification, and if you have done the verification, probably no array is moved. That's why. Yeah. सुना दिया मेरे को उस हाथ से पकड़, ये हाथ दूर का, मेरा मुंह आएगा ना. Pointer. You can check स्क्रीन दिखाओ ना, स्क्रीन रोबोट वाली, इसको हमेशा बने रहने दीजिए, है ना, कंटिन्यू पिक्चर इन पिक्चर बना के रखिए. हाँ, सो वी कैन वेरीफाई दिस इज अ सब मिलीमीटर कट एक्यूरेसी जो दैट वी रिसीव with the robotics. Now after taking the distal cut, I'll take the posterior chamfer cut. Enter. Okay. वहीं से So now the job of the robot is done. ये तो निकल गया. Now we have to mark the position of the peg hole so that we fix the implant properly. Give me the marking pen. Yeah. Give me the trial of. So we mark it. Yeah. With the size 3. Here. We again confirm the position. Give me the pin. Okay. So once this is confirmed, we'll do the peg holes. पिन निकाल देना. Small punch देना. Artery. Headson. Give me trial. Hammer. Eight, 7. So what we achieved is 1 and 1.5 millimeter of the laxity. So clinically, if you see this, there is no FFD. You can see it. Side camera, yeah.
You can see that, yeah.
Yeah. And the joint is also well balanced here.
It's perfect.
Yeah. So now we'll do the cementing and component fixation. I'll just show you also the preparation of the tibia. Hold this. So now the job of our robotic system is over. So I'll remove these pins.
So sir, you planned the amount of bone that has been resected. That is what you planned initially with the robot, or it is somewhat less, more the cuts that you have taken.
Sorry.
So the amount of bone that you have resected for the implant.
Yes.
It is the same as you wanted it at the start, or it has increased, or is
It is the same what I want. Yeah, but approximately 0.5 degree or 1 mm or 0.5
yes,
legs in the flexion. I don't mind.
yes.
I don't want to make it tight at all.
Yes. And you have been able to remove all the osteophytes, right?
Yes. Pin. Yeah. Drill do. Reverse.
And even from the audience, any questions at this moment before we go ahead with the final implant position? So everyone looks happy with the surgery that you are.
The system is very smart,
Yes.
and the cuts are interlinked.
Yes.
So if we increase any kind of cut in the femur, it adjusts itself and onto the tibia. It changes the component positioning also, so that we get a final outcome what we desire.
Yes.
Okay. Give me pro. Give me. So since system allows us to use any size of the tibia along with the any femur, so I'll recheck manually how much size of the tibial component I want to put it. Give me 3. Give me
This system provides with this
Yeah.
independence.
Yeah. 3 size का दो मुझे टीबिया में. लो. फोर देना. 40. Give me Edson. So I'll remove the part of the medial meniscus which is left. And in this patient, invariably we see that the medial meniscus posterior root is torn. Yeah. 4. Yeah, this is perfect. Welcome.
So you're looking at a perfect cortical fit, yeah?
Yeah, perfect cortical set, no overhang from the medial side. Can you see it?
Yeah, that's very important, looking good, yeah.
Yeah. So it should not be undersized because it can sink,
Yes.
and it should not be oversized also because it can impinge the MCL in that case.
Yeah.
So it should be a properly sized, and now I'm doing the keel preparation. It's done perfectly. All right. Yeah. Take this out. Now I'm ready for the cementing. Give me wash. Okay. Yeah, right angle. Pulse lavage on. Yeah. On. चलो चलने दो. I use pulse lavage in all of my cases so that all bone debris can be removed and we get a proper cementing, because cementing is the most crucial step which is important for the longevity of your surgery. Stop, stop. Spike. Artery. Yeah, injection. Yeah, दे दो.
Here at this stage you can check there is a small piece of bone there behind the groove for the keel. So we are sure with the posterior margin as well.
Yeah. Yeah, enough. Cement mixing. चार टिबिया 7 insert. हाँ. Yeah. So once the cementing is done, then I'll prepare the patella and then we'll do the closure. Little amount of cement should be used because it's very difficult to remove it from the back if it gets stuck over there. So it's always better to use minimal but adequate, should not be over. चिपक रहा है. प्लास्टिक का वो टीबिया लगाने के लिए. ला हो गया. No. I don't put cement on the posterior side onto the bone. I just put it onto the implant. गिरा नहीं बहुत ज़्यादा. Only दे दो. हाँ? ला पंच. ला पॉली. मुझे लगता है कि it should go by hand itself. If it's not going, something is obstructing on the way. Give me another spike. Suction.
Is the hyperflexion the cause of that?
No, actually there was a small amount of soft tissue.
Because he's putting in hyperflexion, so the 90 degrees might go easily.
Okay, yeah. This is going. Yeah, it's done.
Excellent demo.
Yeah. Thank you, sir. Thank you.
Clap for him.
Thank you very much, sir. I'll just prepare the patella. Now
Thank you
you
for an
can
excellent
go ahead with your
demonstration.
program. Thank you.
Thank you, Vinay.
Thank you.
So we'll be back to the hall again now after an excellent demonstration of robotics UKR. Now, before we begin the next session, I would like to call Dr. Saket Jati sir on the stage to facilitate our speakers and so I would request Dr. Sundesh Mahajan sir to come on stage and would request Dr. Saket sir to facilitate him. Thank you, Mahajan sir, for traveling all the way from Nagpur and enlightening us. Thank you, sir. I would request Dr. Mandora sir to be on stage to be facilitated by Dr. Jati sir. you, sir. Thank you, sir, for enlightening us with the extended approach indications. And sir, आप ही दोनों हैं ऊपर ही सुना है and Dr. Gohia sir also on the stage for the and Dr. Vivek sir is. Thank you to all the speakers and chairperson for an excellent session on UKR. Thank you, sir. Thank you. Now, after an excellent surgery, live surgery and session, we are now ready with the second session now. That is robotic and emerging technology in knee arthroplasty. And our first speaker is Dr. Ambar Mittal. Will be speaking on augmented reality in arthroplasty. I would request Dr. Ambar sir to be on the stage. Dr. Ambar Mittal has two talks and he'll be giving them simultaneously. First would be augmented reality and second is intelligent technology. first lecture begins now.
So good morning everyone. There was a technical glitch, now that has been fixed. So I would be talking on augmented reality in total knee orthoplasty. So let's go to what is the history of all these chaos. Like we know standard instrumentation was there, but it was more invasive. Then came the era of computer assisted navigation, which were accurate, but they were complex. Then came the patient specific jigs, then robotics. And nowadays, one new tool in the armamentarium is the augmented reality. So there are three types of reality. One is augmented, other is mixed, and third is the virtual reality. In augmented reality, you see the 2D, the information is displayed on a 2D screen. In mixed reality, the 3D objects, they appear in the real environment. And in virtual reality, you see when you go to the gaming zone, so the 3D objects, they appear and the environment is also virtual. So what is this Pixie system is, it has an augmented reality glass with 3D system, tracking system, which is a proprietary. So this forms the AR solution. So I will be just running through some of the videos. So you just scan the QR, you wear a goggle, and then you tilt your neck. If you are to do left side of surgery, left leg, you tilt your neck to the left side. Then for hip registration, you need 10 points. So you circumduct your hip, take it through it, and 10 points are required to register the hip center. So this will give you a mechanical access of femur, and then you put the zig. So here you can adjust the varus valgus depth as well as the flexion extension. Then you pin it. You can even check with your manual that how much you are cutting. You pin it. You can again verify it. You can validate any number of times. You take the cut. And then again you verify your cut. So for knee also, the beauty of this system is that the pins are intra-articular. So there are no extra articular pin. So there is no risk of periprosthetic fracture from the pin tracks. So you acquire the center, so you need lateral malleolus and medial malleolus, 2 points. So this will give you the mechanical access of tibia. Similar procedure you can adjust in varus valgus, slope, and the amount. Then you pin it, you take out the zigs. You can again validate before taking it out. Then you remove the system, then you take the cut. And then you can validate it. So the removal of intra-articular pins does not affect your validation process. So like with other systems, when you remove the pins, you cannot validate. So I will just show you one live surgery which we did in, I think 2 years back in the MAC only. So we operated the patient's right side. So just like Dr. Vinay did our surgery, I did this 2 years back in the MAC 2024. So I do most of my surgeries by Savastas approach. So this is the center of the femur. Then two oblique more pins are required to stabilize it. So total 3 pins go. So these are divergent pins. So one pin is in the center and 2 pins go in a crosswise. So now I am rotating the femur, so I am acquiring the hip center. So 10 points has to be taken for hip center registration. So now you can see this is the mechanical axis of the femur, and by removing the screws you can adjust. You can see like this is showing 3-degree valgus varus, and I am rotating the screw and it is adjusting. So as per surgeon's choice, you can just fix it and then you take the cuts. So for tibia also, we use this intra-articular pins, so there are no extra-articular pins. The pin is in the femur, in the tibia. Then again 2 more pins go to stabilize this because it can rotate. Then you acquire the ankle center by taking medial malleolus and lateral malleolus, so that will give you the mechanical axis of the tibia. So now you can see inside the small screen, you can see a blue line which is nothing but the mechanical axis of the tibia. And the similar procedure is followed, just what we did for femur. We can adjust the slope, we can adjust the varus valgus, we can adjust the resection level. And rest of the procedure is like a standard TK. You can also use for femoral rotation, but in this case we did not use for femoral rotation. We did it in the conventional way. You can verify your cuts. So this is what we did. So the beauty of this system, it has reusable instrumentation. You have a pointer, you have a stylus, you have the guiding tool, and you have a controlling tool. So it's a unique competitive solutions compared to other robotics and other systems. So it has been used, there has been wide clinical data presentation has been there, multiple articles are also there on knee, hip. So no outliers lie in the frontal plane in 23 cases in 1 studies. So this is the different literature which says that the benefit are as good as robotics and without the complications associated with the pins. So I'm not going to go into detail about the literature. So I think we'll jump on to the next lecture. So next, another interesting, this is the same. So another thing which has come up in the market is the IntelliJoint knee. So what is this? Let's see with the help of a video only. So it's similar to that of Pixie, but it has a movable camera. So the camera can come inside the field of view. A laptop is there and the instrumentations are there. Only 3 things are required. It has 2 types of workflow, standard femur workflow or an advanced workflow. So
depending on the surgeon's preference, you can choose either of one. So you can put an extra articular pin, or you can even put an internal intra-articular pin placement. So the advantage of intra-articular pin is there is a less chance of future fracture from that stress riser. And similar, you take the hip through a range of motion, it will take the hip center, then you can take the center for the femur, then you define the right side line, then you paint distal femoral condyle, lateral, medial, then you paint posterior condyles. And it is compatible with any other any implant, so you are not restricted, you are not forced to choose one particular type of implant. You can use any implant. The beauty of this jig is, again, it can help in varus valgus, flexion extension or slope adjustment, and the level of resection. Just like in Pixie, you can just put the screws, then you can verify, you can rotate the screw and your varus valgus, flexion extension, and all these things can be changed. Then you take the cut and you verify your cut. For femur rotation, you can do this. So again, you use it as per your choice of rotation. You want to use posterior condylar axis, you want to use right side line, depending on your choice you can use. And you can check flexion gap also, and if you want to verify, you can. For tibia also, you can use extra articular pin placement or alternate intra-articular pin placement. Then you register the lateral malleolus, medial malleolus, similar to the Pixie. Then you take a lateral center of the tibia, then PCL insertion, then medial third of tibial tubercle, then lateral tibial plateau, medial tibial plateau. That's all. And then assemble your jig. Then you pin it.
We've already had a wonderful live surgery, and perhaps that has image-based active robotics in total knee arthroplasty.
the bone cut, developed a software strategy rather than using one size fits all mechanical. So you need long lead radiograph. You need to calculate the arithmetic HKA and a joint line obliquity. Then you place the knee into 9 phenotypes. And whatever philosophy you want to go ahead with, phenotype, restoring kinematic, or a mechanical approach according to the patient. So McDessie developed the CPAC classification. So you have 3 columns, 3 rows. Columns, it's varus, neutral, valgus, and then you have apex distal, neutral, and apex proximal. So these are the 9 phenotypes. So arithmetic HK is MPTA minus LDFA. So when the HK is negative, it's a varus knee. When it is 0, it's a neutral knee. When it's positive, it's a valgus knee. For joint line obliquity, you need to add MPTA plus LDFA. So when it is less than 177, the joint line is apex distal. A range between 177 to 180, we call it neutral, and when it goes beyond 183, we call it apex proximal. So in Indian scenarios, the arthritic joints, we get type 1, which is the most common, then comes type 4, which is varus with a neutral joint line, and then you have a type 2, a native neutral alignment with the apex distal joint line. So what you do with mechanical alignment, you place all these phenotypes into type 5, a neutral alignment with a neutral joint line, which is not right. What are the key planning steps? You need to measure the native geometry, measure the medial proximal tibial angle and the LDFA angles for calculating arithmetic HK and joint line obliquity. Define the target phenotype, whether you want to restore the native MPT LDFA, restricted kinematic, or to move towards a neutral mechanical alignment. Translate the targets into the bone cuts. So plan the femoral and tibial resection in such a way to reproduce the target joint line obliquity and overall AHK. If you are restoring the phenotype, aim to match native angles within measurement error. And if you are moving towards the neutral, calculate the delta for each bone, and you have to distribute the correction. So with CPAC phenotype restoring, the primary goal is you are restoring the constitutional coronal geometry. Soft tissue releases are very limited. It is best for mild deformity with a low joint line obliquity. In cases when you have a severe deformity with extreme obliquity with severe bone loss, you need to go for a mechanical alignment. And with robotics and navigations, you have the real-time gap check measures, so that whatever you're doing is, you can validate that. So now when you compare kinematic with mechanical, so with kinematic, with good accuracy, you can achieve the native phenotype post-operatively. Now you have to prioritize the joint line obliquity whenever the CPAC phenotype indicates low joint line obliquity, small adjustment to LDFA MPTA, so that you don't need major releases. You should avoid leaving the limb in extreme varus and valgus. So your residual HK should be within plus minus 3 to 5. And whenever the correction is needed, split it between the femoral and the tibial cuts rather than over resecting one bone. And always document the planned LDFA and the MPTA targets. So whenever you have a mild deformity with a lower joint line obliquity, go for a kinematic alignment, match the native angles. When you have a moderate deformity, go for restricted kinematic or a functional alignment, split the correction. And when you have a severe deformity, you need to go for a mechanical alignment with releasing more. So few examples. So in this case, you can see the LDFA is 88 degrees, MPTA is 84 degrees, MPTA minus LDFA is minus 4, means 4 degree of varus. MPTA plus LDFA is 172. This is CPAC type 1. Now what should be our targets? MPTA to 86 degrees, means we have to cut tibia in 2 to 3 degrees of varus. LDFA unchanged to 88 degrees. So the result will be 2 degrees of varus deformity will be left, and you have achieved the apex distal joint line. Another case, now here the LDFA is 92 degrees, MPTA is 84 degrees, there is 8 degrees of varus, and MPTA plus LDFA is 176, means it's apex distal joint line obliquity, means CPAC type 1. This is the post-operative scanogram. Now only 4 degree of residual varus is left. MPTA plus LDFA is 176, means you have maintained the apex distal joint line. So here the idea is you need to calculate these angles for MPTA, your target should be around 87 degrees. Means you have to cut TBI in 2 to 3 degrees of varus. For LDFA, in severe valgus knees, if we talk about, in severe valgus knees, usually your LDFA comes around 83 to 82 degrees. You need to come down to 87 degrees, means you need to give varus to the femur. Here in severe varus deformities, you need to give couple of degrees of valgus to the femur so as to reduce the LDFA from 91, 92 to 89, 90. So in this way, you can just manage it. Now, what are the risks? So when you try to restore the constitutional varus valgus, it can, if extreme, it can increase the asymmetric load on the implants. And CPAC only gives you idea about the coronal, in the coronal plane. You still don't know what all sagittal or rotational deformities issues are there. Early evidence shows if you compare kinematic versus mechanical, this is preferable for mild deformities, but still larger outcome studies and long-term implant survival data are ongoing. So I'll conclude by saying that CPAC is crucial for maintaining the patient's native coronal phenotype, reducing unnecessary ligament release. I won't say soft tissue release, unnecessary MCL ligament release. And then implementing CPAC and routine planning makes alignment decisions measurable, reproducible, and patient-specific. Thank you. Any questions?
Thank you, Dr. Akhil. Any questions for him? I would like to join, tell Dr. Ambal and Dr. Nikhil to join Dr. Akhil on stage. So, as we are about to conclude our second session, we'll ask the speakers and take questions from the audience now. We are also getting ready for our live surgery now, so we'll just hurry it up. Any questions? Vinay?
So, my question is to Dr. Ambar Mittal, because he is technically or technologically most advanced among us. He is using all the systems. He is using the robotic system. He is using the augmented reality as well as IntelliJoint system. I think IntelliJoint is a sort of navigation system. So what among these three is most convenient to you and take less time, and personally you will endorse one among these three?
As you see, even robotics is also based on navigation. And I would not advocate any one particular system. It has to be the surgeon's preference and surgeon's compatibility with the particular system. Like my conventional, I do TKR, my tourniquet time is 30 minutes. And when I do with IntelliJoint, it increases to 32 minutes. So that's it only. But if I'm using all the parameters, I do not check all the parameters. Most of the surgeries, I do not use this technology for rotational alignment because I feel you can do it manually also. It does not give you bad result, but it's entirely up to you. Another advantage of IntelliJoint is it gives you real-time data on cup position and anti-version. So that is advantage with compared to Pixie or any other robotic systems.
For hip, we all agree. I think IntelliJoint is
slight
has an edge, because
but still I would not say robotics or any other advanced augmented reality or IntelliJoint is better than conventional. If you do conventional properly, there is no substitute for it.
And what's your take on Akhil on this? Robotic or conventional?
Basically, a surgeon should be well versed with conventional surgeries, and then he should opt for robotics. And yes, robotics has an edge. At least as an image-based system, we know everything beforehand. We do the planning. We get 0.1 millimeter accuracy. Even a skilled surgeon, हाथ का कारीगर कितना भी अच्छा हो, लेकिन गलती हो सकती है. So it's like with robotics, you can pre-plan everything. You can manipulate with the component positioning as well, which is not possible with navigation systems. You can play with each and everything. And the one thing I'll say, you can deliver consistent good results. No chances for human error if your planning is good.
So what's the extra time you spent on robotic system? If you do it a conventional surgery, as you said that if you are mastered the conventional, then only you should go to the robotics. if you are giving extra technology or extra advantage, how much time a surgeon has to give more for the surgery? If
So it will be 20 to 25 minutes more
okay, in a robotics
in
system.
robotics, sir.
Yeah. So my experience with Wellness is you have to give hardly 5 minutes extra then, because this navigation system, IntelliJoint, as Amber said, or the Wellness, basically based on the real time. Advanced version of navigation is, you can say, is the Wellness one, where you have a robotic precision or robotic arm added to it. So you don't have CT or the much complex things along with that. So in between the conventional and fully active robotics, I place these systems which take little extra time, hardly 5-10 minutes maximum, but gives the advantage of robotics along with the conventional procedure.
Sir, my question to Akhil sir, regarding the CPAC, so regarding if preoperative CPAC, whatever it comes, so do you start with a mechanical start point or a kinematic start point?
It depends on the deformity. So if the deformity is mild or moderate, it will be kinematic start point. And then it depends on how much deformity, as I said earlier. See, if it's more than 10 to 12 degrees of varus deformity, it will be a mechanical start point. If it is less than 10, it will be a kinematic start point. And my parameters are clear, like MPTA should not be less than 87, right? So it's like you are cutting tibia in 3 degrees of varus, that's a limit for me. And then in femur also you can change 1 to 2 degrees here and there,
So
not beyond that.
If you start from a mechanical start point, all your CPAC will end up in CPAC
Yeah,
1.
5.
So
It will be
that
5.
ways you won't match the preoperative.
Yes,
so
of course. It's
everyone
very
will
difficult.
land in CPAC 1, or if you don't give that much of RS.
So
in CPAC.
sometimes
So
when you do with robotics also, majority of time you convert type 1 to type 2.
yes,
And
correct.
with mechanical, every time you end up in type 5.
Any more questions? So I would request Dr. Ashish Bhuria sir and Pranav to be on stage to facilitate our speaker. And I would also request Dr. Pradeep Chaudhary sir to join. It was left in the last previous session. लाइव सर्जरी की तैयारी करनी है, इसका लाइव सर्जरी करना है। Thank you everyone. We are also ready for our second surgery now. Dr. Udmesh Mahajan is in the OT now for demonstrating Wellness TKR.
Yeah.
Hi, good morning, good afternoon.
Sir, you are clearly audible and visible, sir.
Thank you so much.
Good afternoon, sir.
Thank you, Vinay, for giving opportunity to operate once again in your setup.
Thank you very much, sir, for accepting the invitation once again.
It's an honor.
Yeah.
Don't worry.
Thank
It's an honor to be here. So let's start. We have a gentleman who is, what's his age? You can see X-ray which shows a medial OA, of course, with a lot of varus deformities. And it's the right side. So yeah. So now we are done here with the positioning, prepping and draping. And that's the position 90 degrees in the on the foot. Okay, sorry. Okay, can we start incision? All ready with incision? Okay. One second, yeah. Okay, can you just put the saw? Saw is done, na? Get a saw. Saw laga do uske upar mein. Yeah. Okay, chalega. We'll set up the robotic part. Yeah.
Sir, since we know that you do all your cases with the robotics or you use the technology since so
Yeah,
many
please,
years.
no, done, it's already done.
Hello? Sir, are we audible?
Yes, slightly, yes. Can you
Yeah.
increase the volume, please? Can someone come stand here, please?
Hello? Hello? Are we audible, sir?
Yes, sir.
Sir, my question is there any situation when you do not prefer to use the robotics?
Last 3 years, we are not a single case which we don't do robotic. So every case can be robotic because it gives more information to you than any other conventional methods. So let's start. My thumb is always on the tibial tubercle, and that's where the incision should not be on the tibial tubercle. It should be slightly medial to the tubercle. Okay, that's the incision part. Yeah, 1 second. That's exposure of the knee here. Forceps, please. Slightly bigger forceps. Yeah, thank you. So, bit of a small flap on the medial side, not much. Just to make sure you are at the tibial tubercle. Here, that's the exposure. And here I can see a quadriceps here on the front. So, that's initial exposure done. Now, what we'll do is we'll use a trivector approach, where a right angle to him, please. Here I'm going in a 1 centimeter of muscle. Now around patella. Can the cutting be increased? And here the inferior incision goes close to tibial tubercle. Make sure you have a centimeter of cuff to approximate the edges of the inferior part. Can you increase the cutting, please? Okay. Yes, that's better. So there is a cuff of tissue. I think this will be important for suturing because maximum leakages happen from the inferior part, and one should be very, very careful to dissect this part of the joint. 1 second, I'll just improve. Okay. Cutting improve हो गया ना? और थोड़ा बढ़ा दो cutting के लिए please. I'm struggling with the cutting part. Okay, that's great. Thank you. Okay, now if you do a robotic one, the exposure is slightly different in the sense you don't remove everything from the medial side up to the midline or beyond that. If you see the exposure only going to the midline of the tibia, midpoint of coronal plane here, and that's all it is. Also, इसको cutting का कुछ. That's all it is. Now we'll remove the osteophytes on the tibia and the femur. Thank you. The medial osteophytes on the femur as well to be removed as a normal procedure. Then we extend the knee joint. Can you give me a blade, please? I think it's the cutting is not as good as it should be. Force it, please. Thank you. So right angle to you, and right angle to him as well. Okay, that's it. Huh? Okay, we'll remove this superior synovium from the superior surface, so I can see the superior margin of the anterior part of the tibia, sorry, femur, the femur, where there is a, I have to get a access for the anterior registration. That's it. And then I remove here, I remove the inferior fat pad. Okay. Here I can see the patella here is small osteophyte, not much, will be okay by just doing a removal of osteophytes. And here I'm going to open up slightly. That's fine. Thank you so much. Yeah. I'll try to do that. Yeah. Okay. Now that's knee exposed. We just remove the PCL part now, the ACL part. Can you see us very well? Yeah.
If
Nice.
anybody has any question here, we can discuss.
Yes, we are doing the removing the ACL part, ACL now. PCL is kept intact as much as possible.
So there is a question that you do CR knee in all the cases, sir?
Yes, 99.9% nowadays, bone lever. Now that's the big thing is how to get a tibia forward. We'll just put a simple wala bada.
Sir, is there any, because you have done PS knee for years and
Yes.
now you are doing CR for almost all the cases now.
Yeah.
Do you find any difference in the
I think
functional-
I'm happy that I'm not removing a lot of bone. So here now I'm just going to remove this part of the deep MCL here, and that's it. I can see the tibia coming forward. That's all release has been done. Now one more retractor from the lateral side. Okay, here can you hold this? Thank you. And forceps, please. Forceps and knife. So I'm going to see this is the exposure of the tibia required here. Sorry, knife. अभी चल रहा है थोड़ा ये चल रहा है हाँ चल रहा है अभी थोड़ा So I'm just going to remove the lateral meniscus and that's it. See now if you see with the patella without everted, you can see everything now here. You can see the posterior part of the tibia, lateral medial margins here and the femur. That's all it is. So that exposure is done. Now we'll put the pins on. Okay. So, tibia first. Give me a 11 number blade. Yeah. Now here I do one pin inside, one pin outside. That's it. 1 second. Where do you keep knife? Yeah, thank you. Pin please. So the first pin goes around tibial tubercle here. That's good one. Next, this array. Okay, that's. Sorry, ulta. Okay, second pin. Here. That's the tibial pin put in. Yeah, okay. Right angle, please. Right angle. That's it. Okay. Pin do, please. Bada pin. Always bada do. So here now the pin goes close to middle epicondyle. Can you hold the femur, please? Here. Okay. And one pin goes just above that. There is 1 centimeter above the epicondyle more or less. And that will not be in the picture as well in the way. And they are within the incision. So here I'll just tighten this up. We put arrays. Array de do mujhe. Femur array hai. Okay. So make sure the arrays are put in and they are tight. Good enough. Okay, they are good enough. You're tight here. That's fine. And here I am tightening myself. Make sure this is tight enough. And this is good. So this is good. This is good. No signs of trouble. Okay. So what we'll do is we'll do the handshake. Just can you just hold it? Okay. Tighten the clamp. Take the machine up, please. Machine up. Up, up. Okay.
So, sir.
Yes, please.
One question: do you prefer the machine mounted on the table or the pre?
I think you should always mount the machine on table. There is no second thought to it. Those people who don't mount can lead in more trouble because of the vibrations. So I think mounting the machine is the paramount importance, and that's the way it should be promoted actually. Some people are promoting without it, which is not the right option. I think I would rather tell everyone to have a mounted machine.
Sir, you don't worry about the sterility because like it is mounted on the table and the grapes.
Yes, no, we have a method of doing it. It's very, very sterile. Don't worry about that part. Okay.
Thanks.
You have to train your assistant properly, the guys in the OT, to make sure they know what they're doing and without causing any disruption to the sterility part. Okay, so here, we're adjusting the whole thing. That's slightly behind, yeah. Okay, now we can see all the arrays here. That's very well. So we'll start with the point. Now what he showed was right, Vinay showed was right. I take the point on the array itself, which is more easy. And this is now we are getting the femur point here, the rotation part. That's the easiest part is rotation in this machine compared to other machines. Okay, can you hold the leg please slightly? Okay, medial point. The lateral point is the most prominent point of the lateral malleolus. Then comes the central point of the tibia, which is the center of the ACL, PCL.
Please show the robotic screen on the PIP.
Robotic screen, please. PIP में वो दिख नहीं रहा है, हाँ? नहीं, हाँ, अभी नहीं, robotic screen नहीं आया उसके अंदर में. ये वाला screen दिखा दो. Okay, आ गया. Other way around, उल्टा करो उसको, उल्टा करो. Okay. Change किया? ठीक है. Now that's a medial point. That's a lateral point. And
जी वो PIP को switch कर, swipe outside.
Inside out करो, उल्टा करो उसको. This is the central, sorry, axis point. Where is the? Okay. And that's a right side line. Now I go for a medial side. That's a medial. Then the lateral. Now the posterior medial. The posterior lateral.
So lateral compartment is also good in this case also.
Yes, you could have done possibility of a UKR there, but anyway, we have to do this. So now that's the anterior margin there, and this is very important. Is a 0.4 or 0.2? That means that much up. You have to take it up. Lateral we'll check. It's green, posterior green, medial green, and the medial part green. So all is green. That shows it's very well. Models are very accurate, almost to a tune of 0.2 millimeter. So that's the first graph we get, equivalence graph. And here you can see the deformity is around 7 degrees of varus and not much of a flexion deformity. That's fair enough. Okay. Now here, what you look at the graph, lower down is the 0, is the flexion part, 0 extension part. No, just show on the screen. 0 degree extension, and that's the flexion is above. You can see, and at 90 degrees with the flexion, around 12. Yeah, that's so 12 on the medial side, 10 on the lateral side, 3.5 on the medial side in extension, 9.5 on the. Now the planning screen. So let's plan first tibia. What we do is the inverse kinematic. So 1.5 degree varus on the tibia. That shows 9 millimeter on the lateral side, 3.5 on the medial side.
Robotic screen big कर दीजिए please.
अभी big कर दो.
Yeah, thank you.
Yeah, 1.5 varus on the tibia, which is very close to MPTA, not 100%, but close to MPTA. Now 9 is the lateral side. This is minimum requirement. 3.5 in the lateral medial side, and instead of 5, we'll go for 6 degree slope for a CR knee. Okay. Now that's a TBI management. We don't look at the femur at all at this stage. We just do a tibia first and we go to tibia. So can you have two retractors, please? Retractor, center wala bada. Bada. You can you hold this for me? And एक lateral wala retractor, lateral wala. वो दे दो ये वाला. हाँ, ठीक है. That's fair enough. हाँ.
छोटी स्क्रीन रोबोटिक.
अभी मशीन आएगा रोबोटिक का? नहीं कुछ जरूरत नहीं. ठीक है, रख दे. अच्छा ये. हाँ. Okay.
Outside.
Yeah.
Outside image.
Yes, outside image नहीं आ रहा है मेरा इसका. Hold it this way.
Sir, there is a question
yeah.
about the inverse kinematic which you are saying.
Yes.
Can you please elaborate it?
Yeah.
And show the outside images. Yeah, thank you.
Okay, now I got a, you can just hold it there. That's it. Okay. Okay. Can you have a straight osteotomy? Straight there. So that's a tibia coming out. Okay, thank you. So well, first we'll remove this biscuit. इसको ऐसा पकड़ दो हाथ से. हाँ. Okay. Focus yeah. Okay, that's good. So here I'm going to take off the part of the posterior meniscus, and some part of the PCL as well is going to come up with it, but that's okay. Okay, that's the tibia removed here. We can see 9, and this is very minimal on the medial side. Okay, small part of this thing is left on the lateral side. Saw, please, hand saw. Because that is behind the patellar tendon, so we can't really go there many times. So I'll just remove that part with a piece of, and we'll then do the rest of the job. Here, once I cut the tibia, I'll check the tibia first. Let me first remove this. Okay, that's the remove. Okay, coccus, please, something like that. And can you give me a tibia size 3, please? So at this stage, we have to check the tibial size because that will guide me on the femur. So one more small check is important to make sure we know what we are doing. So here 3 will be okay here because the femur might be 4, but it can be 5. So we'll just see how things go with the femur. So that's a tibia done. Here I can check. Can you just give me a pointer, please? Pointer. Yes, here we can check the tibia again. For you guys, it's 0.5 distal. Otherwise, it's good. That's quite good tibia here. And the slope as well. If you see the slope here, I'm putting the slope around same thing, 0.5 distal. Okay, that's it. That's better. So now we'll put this is a tensioner. If the camera is here, you can see the tensioner here. Okay, the tensioner has got a arm which has got equal pressure on both sides. And I think that can be seen here. Okay,
yes,
so
we can see.
Yeah, I've got a small one. Okay, there are 2 sizes, a big and small. Depend upon the size of the femur, you can put it. From 2 to 4 is small, and beyond that is 5. So I put in a sensor tensor that has gone in, and you can see now, if you see here, okay. Now if you see here, the important part is, give me a handle, I'll show you. Can someone put a right angle there on the other side? See, here is a part. I can see it is loose on the medial side here, coming out, okay? And thus, so I know I have to tighten this medial side up, and that's where the whole thing is. So we'll get one more graph now. The graph will be, now with the sensor tensor in, we just have to take a graph like this, and here, I can say it's almost coming to 1 degree, a correction of to 1 degree or 2 degrees, and that's fine. So now, based on this graph, reverse kinematic is that I cut the tibia first. And based on this, I'll change the femur accordingly, so to get the things right. Now here, we have graph of 13.5, 13.5. What we require is a -3 on the medial side. So first and foremost, we'll change the size to 5 because it's a large deformity there. So we change the rotation now. Rotation minus karo. So interrotation of the femur here by almost 2-3 degrees, or bas. That's 2.5. Now we can go 0.5 up on the femur just to get to avoid the notching of the femur. Okay, and we can here at this stage we can just flex 0.5 on the femur just to make it. That's it. Okay, that's perfectly fine on the medial side. Now coming to extension part is 10.59. So we'll just go for a 0.5 varus on the femur. So that's 10, 10, 12 and 9.5. That's perfectly okay with me. If you see the posterior condyles, we are only cutting 6.5 on the femur, and that's a 3.5 flexion of the femur, and that's about it. So we are doing well. Here we can say 0.5 up, we can go 0.5 up on the femur because it can go in hyperextension. So just we are going to cut less. We go 8.5 in the femur, so that's perfectly fine. Almost 3 values are matching. Other is 2.5 more, that's perfectly okay for a CR knee. So we'll cut the femur now. Okay, right angle and bone lever. Okay, that's for him. So we'll go with the anterior cut first. Okay, now the femur, the anterior cut of the femur, and if you see this, there is no notching here, if you can appreciate that part. Again, still you have a what you call a piano sign slightly. So introduction of femur is compared to the posterior middle condyle. So there is no notching much of here as such. Okay, we'll go for a chamfer cut now. So here. पैर पकड़ो सिर्फ. We'll check the things with the pointer. Pointer, please. Sorry. So here you are almost 0.5, again 0.5. That's pretty good. So we'll go for the distal cut now. In that sequence, so I'll have a lateral here, okay, and the medial on this side, yeah. So very minimal tissue retraction is required. You don't require to retract much of it. So we'll check the distal part now. Pointer, yeah, that's pretty good. 0.5 to 0 and 0.5, and here again 0.5. Okay, that's fair enough. So good one. So we'll go for the posterior cut now. We'll hold it. Okay, thank you. So that's the posterior cut of the femur. Hold the femur. That's good, okay. Don't worry about haptic boundaries. You are doing a saw every day, so you know what to expect, when to remove the saw, and that's the last cut is going to be the okay, we are done with the cuts at the moment, and we'll do the trial once we remove this. Thank you. Now the machine can go up on that side.
But you have changed the sequence of cut.
Yes.
Particular reason for it?
I'm used to that cut because if I do anterior cut first, I can go down if I require. Okay? And that's the easy way of doing it. Posterior, please. With thousands of cases, I know this is the best way to get it easily done, sorted out. Caucus, please. Yeah, thank you.
Because normally the system says that you take
Yeah, but you can't follow system all the time because what it makes is more comfortable for yourself.
So the sequence can be changed at any time.
Yes, you can. That's the convenience part. Now, if you see here, the meniscus is still there, so I'm going to remove the meniscus now. You can just remove that. I'm holding the meniscus here. Okay, that one. Thank you. Can you hold the femur up slightly? I see the posterior condyles of the femur. Meniscus pakad lo udhar ka. Haan, bas, that's better. Thank you. Now I remove the meniscus part. What is there on the posterior part here? Because here the meniscus serves as two purposes. It serves as as a MCL protection. And that's it. Okay. So nothing is there as such. Okay, we'll go for a trial now. Trial, please. इसको निकाल दो उसको हो गया काम उसको 5 का trial. Okay. If you see the trial is fitting extremely well. Here, can you just zoom in case someone wants to zoom in? The trial is fitting very well. Both sides, lateral, medial, is perfectly fitting. Okay. Now size 3 and 4. Sorry. Okay, that's fine. That's good fit of the things. Let's see how things fare up on this one.
Since now this Johnson & Johnson is providing the MS insert also.
Yeah.
So medially stabilized.
Yeah.
So what is your preference? Which insert you use?
I use MS in case there is a small loosening on the middle side and young patients. In old patients, I might use a standard PS CR insert. So now let's see here. We can see the full extension possible, and with that's good 2 degree varus, 1 degree flexion, and a good graph here with a 6 mm poly. I think that's medial lateral stability, full extension, and you can see a patellar tracking extremely well with that interrotational cut of the femur as well. So that's important. People are scared of interrotation, but that's a way to get a balance right. Okay, that's a way to get a balance right in terms of your okay. Here
balancing and equalizing the flexion and extension gap.
Yeah.
Dixelize the fragment as well as
yeah.
We have created some more flexion.
Yeah.
Femoral component.
Yes, both ways.
And increase the size of the femoral component.
Yes, that's, see, you have to manage the flexion gap well. Flexion gap can be only managed by either increasing the size, decreasing the size, rotation, and up and down the femur. We can do femur in both multiple planes. Flexion of femur, deceleration of femur, we can take it down, up, maximum by a millimeter, not more than that. And the rotation is the key to all those things. People are scared of rotation.
Yeah. So the advantage of the robotic system is that they give you freedom to
Yes.
move your component in internal or external rotation, and at the real time you can see
Yeah.
the gaps are balancing.
Okay, shall I remove the robot
Yes,
now?
yes, sir.
Thank you so much. Thank
you
you.
very much, sir, for a nice demonstration.
Thank you.
And very quickly you have shown this.
Yeah.
We will have some questions once you come here.
Yes, please.
Yes.
Thank you.
Thank you very much.
Thank you.
Although we are running little late in this session, we'll continue with the session, and after this we'll have lunch. And one more announcement to all of you, that we will have one more live surgery, which will be a conventional total knee replacement surgery by Dr. Ambar Mittal immediately after the lunch. So please stay for that surgery also. And we'll proceed with the next session. Over to Harsh.
Thank you, sir. I request Dr. Sakajati sir to present his talk on technique in primary total knee arthroplasty and balancing.
So, good afternoon, everyone. After the series of robotics, back to the normal which we have been trained with. So, I'll be speaking on techniques in primary total knee arthroplasty balancing. And as the INSAL said, the TKR shouldn't be thought of as a soft tissue, should be thought of as a soft tissue operation. Failure to address this soft tissue envelope will end up into pain, stiffness, and laxity. We all talk about happy TKR, and it is the proper bone resection, soft tissue balance, both medial and lateral side, and the gap balance, which we achieve both in flexion and extension. So the principle of soft tissue balance gives to equal and rectangular gaps between the resected bone surface in extension and flexion, and equal tension on the medial side and the lateral side of the soft tissue. And we have to keep in mind that we don't have to change the anatomical joint line. So we use three techniques, either the measured resection technique or gap balancing, or combination of both. In measured resection, we remove the osteophytes, we remove the femur cuts and the tibial cuts, and we achieve the grand piano sign. And in extension gap, we take femoral cuts, 5 to 7 degree valgus, tibial cut, remove the osteophytes, and see the extension knee balance, insert the spacer block, and if it is tight, we remove the ligament. In flexion, we do the same, and sometimes we have to use the lamina spreader, and then we take the tibial cut parallel to stripicondylar line, and if symmetrical and equal to extension, insert the cutting jig and take the anterior femoral and posterior femoral cuts. And if not, release the ligament. Normally we prefer combined techniques where we take distal femoral, tibial resection, extension gap, and then we take the anterior and posterior femoral cuts in 3 degree external rotation, and then we see the extension gap. We have to keep in mind that distal femoral cut affects the balancing in extension, the posterior femoral cut affects balancing in flexion, and the tibial cut affects balancing in both flexion and extension. The failure in TKRs are resultant of if it is in a varus knee, pre-op there is tight medial side, and trial component shows that it is tight medially. But if we remove the additional tibial cut, it results in open book medially. In valgus knee, the anatomy is complex. Rotation often affect, it is difficult to discern, and the effect of the deficiency of posterolateral condyle is to be considered, and insufficient lateral side release results in unstable arthroplasty. So the varus knee, there are various scenarios. If it is balanced both in extension and flexion, perfectly fine. If it is tight in extension and balanced in extension, it might be due to tight anterior superficial MCL. We release it in flexion. If it is tight in extension, balanced in flexion, then maybe it is because of tight posterior superficial MCL and the posterior capsule. We release it in flexion. And sometimes we remove the posterior capsule also. Or otherwise, we downsize the tibial component so as to give functional lengthening of the MCL. So we all know that varus knee is challenging. This is one of the example of one lady, bilateral varus deformity, and we followed this and resulted in wonderful correction of the deformity, and now it is almost 2 years after the surgery, and she is perfectly fine. So approach to varus knee is standard approach, sharp dissection onto the proximomedial tibia. Dissection interval is above the pace but below the joint line. Subperiosteal elevation, remove osteophytes, bone cuts, assess the ligaments, soft tissue tight or before proceeding. And if it is tight in extension, posterior half of superior MCL, superficial MCL is primary factor. Anterior medial capsule can also contribute to it. Tightness in flexion, anterior half of superficial MCL is important. or taken care of. Semimembranous or posterior medial capsule may be tight. Fixed varus deformity, you have to check the gap symmetry, medial and lateral side, release anterior portion of MCL. Flexion space should not be excessively tight. You take care of that. Fixed varus knee extension, sequential subperiosteal elevation of posterior portion of superficial MCL is done. Ensure symmetry, both medial and lateral side, and knee must come to full extension. So role of bone resection effect upon the bone balancing. The tibial resection in coronal plane will affect soft tissue, and femoral rotation clearly affect the soft tissue tension, specifically in flexion. The balancing in valgus knee. So we have to remember that after the cuts, the less bone is to be removed than usual, 6 to 8 mm from the unaffected medial side. And bony correction, the femoral cuts, excess is usually 3-degree external rotation, ligaments are still tight, and tibia in valgus position. So if it is extension balancing inside out, take care of the posterior lateral capsule or iliotibial tract. Sometimes we have to do pie crusting of the LCL itself. If it is tight in flexion, pie crusting the popliteus tendon, but not to be started by LCL then. The LCL and posterolateral corner then lateral epicondylectomy, but very rarely. If it is tight in both popliteus tendon and LCL, and then lateral epicondylectomy. So the choice of implant is, if there is no laxity after release, it is PS knee, and sometimes constrained condylar implant can give you better results, but we have to avoid injury to popliteus, peroneal nerve, and the patella baja. So the valgus knee, fixed versus correctable, we have to assess if there is associated bone loss, tight is in flexion, extension on both. The status of MCL is to be addressed. Medial parapatellar approach, minimal medial side release, tibial resection, minimal cut perpendicular to the shaft, and femoral resection. Lamellar spreader is the best device to help us. Pie crusting of the posterolateral capsule and the arcuate complex. Leave the popliteus intact, can result in flexion instability in varus. The tie structures are iliotibial band or posterolateral capsule. Pie crusting is always useful, and slow and gradual release works the best. Final product, equal ligament balance both on median and lateral side, and equal gap balance, flexion, both in flexion and extension. So adhering to the concept of sequential release, majority of the knee can be corrected with the use of additional constraint if needed from articulation. Nowadays, we don't use patella resurfacing, but this is how to prevent the patellofemoral maltracking. The sagittal balancing in primary TKR, the flexion contracture, inability to fully extend the knee after insertion of the trials. So with knee in flexion, remove posterior osteophytes, release posterior capsules, check the PCL, complete release, increase distal femoral cut, not tibia, otherwise it will result into patella alta. Sometimes the gastrocnemius release may be medial or lateral. So this is the sagittal plane balancing, symmetrical gap, address tibia, asymmetrical gaps, address femur. And these are the scenarios: tight in extension, tight in flexion, symmetrical gap, cut more tibia, loose in extension, loose in flexion. If it is symmetrical gap, thicker poly can be used, or tibial metal augmentation. If it is extension is good, flexion is loose, and there is asymmetrical gap, cut too much posterior because of too much of the posterior femur, increase size of the femoral component from the anterior to posterior, and you may have to fill up the posterior gap with either cement or metal augmentation. Extension good, flexion is tight, asymmetric gap, decrease the size of femoral component from anterior to posterior, recess, PCL, check posterior slope of the tibia and the recut of the anterior stroke. So the 10 commands for a happy TKR is careful clinical evaluation, beware of rotational masking and the overestimation, prefer flexion extension gap technique over the major resection technique, because later may give rise to mid-flexion instability. Do not elevate the joint. Address posterior osteophytes, loose bodies early in our surgery. In combined deformity, release posterior medial corner from tibia in varus deformity, posterior lateral corner from femur in valgus deformity. Be prepared to do posterior capsule release and gastroc release in extreme cases. Estimate collateral stability at 20 degree, 40 degree, 60 degree to prevent mid-flexion instability. We must keep it in mind that deliberately leave rheumatoid knee at 5 degree FFD because they will eventually stretch out later. Consider pre-op splint release in massive FFD and post-op splint in stretching. The primary TKR, the understanding of pathoanatomy is crucial. Correction of deforming forces is vital to successful outcome. Know the limits of your prosthetic implants. Thank you so much for patient here.
Thank you, dear sir. Any questions? I invite Dr. Anish Garg sir for his talk on flexion contract.
Good afternoon, everyone. Thank you, MAC 2026, for giving me the opportunity. So, this is the most common deformity we encounter while doing the knee replacement. FFD, fixed flexion deformity. So, what is FFD? It is basically the inability of the knee to extend fully. So, what happens because of that? The abnormal alignment leads to more pain, gait disturbance, and more energy while walking. So what we need to assess is like what are the causes of that, how to assess it, what we can do to correct it surgically, and the rehabilitation. So in clinical assessment, 10 to 15 degree of FFD, it is usually there with varus deformity. Valgus deformity, usually there is recurvatum. In deformities like this, especially in sometimes like rheumatoid patients, if the deformity is more, but most of the times it is because of the muscular tightness. So while under anesthesia, we see the patient, the deformity corrects many a times. So what are the challenges? Like there is varus valgus associated deformity, altered axis. We need to balance the gap and preserve the joint line. It is mild, moderate, and severe. The FFD less than 20 degrees, mild FFD. Moderate 20 to 30 degrees. Severe is if it is more than 30 degrees. So pathology, what are the things that lead to the fixed flexion deformity? Mostly it is the bone blocks, osteophytes, which are on the posterior side of the joint. So here we can see there are osteophytes posteriorly. So they lead to the stretching of the capsule and inability to extend the joint fully. Now the previous history of trauma or any other soft tissue contractures like posterior capsule, collaterals, hamstrings. So there is the convex anterior side and concave posterior side. Theoretically, we have to release the concave side to achieve the balance. Surgical tips, exposure, osteophytes. We need to remove the osteophytes first. We need to take the measured resection. Measured resection means the standard resection we take. Then we have to evaluate the flexion and extension gaps. Usually in fixed flexion deformity, the flexion gap is more compared to that of the extension gap. So while doing the surgery, if you encounter that, you need to release the capsule, and after releasing the capsule, you again assess how it is, and you can recut the distal femur again 1 to 2 mm, but you have to be careful not to go too proximal because there are two things. One, there is attachment of the collaterals, so if you go too further, so the collaterals may be damaged. Second, there is the chance of instability, mid-flexion instability. So what is mid-flexion instability? basically your joint, your collaterals are stabilized in flexion and extension, but somewhere between 30 to 60 degree of flexion, the collaterals are not that tense enough, so the patient has a feeling of give way while walking, and there is continuous pain and instability in the joint. So because of that, the patient may also fall because of mid-flexion instability. What soft tissues we can release? Posterior cruciate ligament, posterior capsule, and gastrocnemius. So as I said, excessive distal femur resection, it is easy, but it elevates the joint line and leads to mid-flexion instability and stretches the collaterals also. Also, there is the problem of the patellar tracking. If the FFD is very high, like if it is more than 45, 50 degree, and you are unable to correct it with the regular implant, with the regular cuts, then you can also use the constrained knee. You need to keep it if there is, like you encounter a patient with FFD more than 50 degree. So post-operative active exercises has to be done, because what happens is, when you correct the deformity, FFD, by taking the cuts, removing the osteophytes, but the quadriceps muscle, it becomes weak. So there is definite extensor lag. You need to keep the brace initially for a few weeks, because the hamstring muscles, they are stronger compared to that of quadriceps muscle, and they have a tendency to pull back the knee back in flexion. So to avoid that, you need to keep the long knee brace and to maintain the full extension. The aim of the surgery is to avoid residual contracture in the end. Try not to injure the popliteal nerve and the tibial vessels. So there are two cases. The lady with varus and FFD, so corrected, and because of the weight we put a small stem. And second, FFD with the severe tibial defects and the posterior osteophytes. So after surgery, we put the screws also. We removed all osteophytes, and the patient got a normal walking pattern. Thank you very much.
Thank you, Anish sir, for such a detailed and expert view. Any questions for Anish sir? Thank you. I invite Dr. Abhijit Pandit sir now for his view on pre-op planning and how it transitions from primary to revision TKR.
Thank you. Good afternoon, everyone. I thank Dr. Vinay sir and team for having me here today for the talk. So, I have some limitations in my talk, so as we have got another session on revision, so I'll like to cover maximum over here. So, use of preoperative planning is important to avoid unstable revision knee. So, we don't need revisions of revision. Knee with constrained, unconstrained implant can be unstable if flexion extension gap is not balanced, as we all have talked about it since morning. Finding the appropriate joint line during the surgery is difficult, and the joint line position should also be determined pre-operatively only. Using pre-operative planning techniques will be helpful in the revision surgeries. Evaluation starts from the moment we see the patient in our outpatient doors. Understanding the cause of the prosthetic failure even before proceeding to the joint revision is very important. Patient's history, medical records analyzed to seek for any anomalies and discrepancies. Walking gait, knee range of movement, ligamentous laxities, instabilities have to be closely evaluated during the clinical examination of the patient. Always mandatory to ask for the original x-rays from the patient, that is pre and post-operative. Laboratory examinations should include your ESR, CRP, and are routinely performed before the revision surgeries. Laboratory abnormalities or in suspected case of unclear cause of failure, joint aspiration is highly recommended, and as we all do it. Synovial analysis, fluid analysis permits assessment of leukocyte count, polymorphonuclear cells, percentage to obtain the fluid cultures. And as the radiographic evaluation, AP, lateral standard, skyline views are routinely done to assess the implant position. Role of nuclear medicine has been mentioned in the literature, but it is not used commonly. MRI is very important, especially when we suspect some soft tissue infections or problems. Joint line evaluation, the correct joint line position is determined by the femoral component position and size. The correct femoral component size is determined perhaps from the contralateral knee in the case of a revision scenario. Surgical approaches, aim remains to obtain adequate exposure, protect the extensor mechanism, facilitate implant removal without compromising on the host bone stock, allow for the accurate implantation of the revision component. Soft tissue balancing without endangering the delicate soft tissue envelope. It is always recommended to use the previous skin incisions. In case of different surgical scars, the most lateral one should be the one which we should use to avoid the devascularization of the lateral skin flap. Subcutaneous flap must be avoided in revision surgeries. When skin flaps are necessary, it is always rather necessary. Undermining of the skin should be done in continuity with the superficial fascia. Patient with multiple scars and densely adhered skin must require additional measures. These patients should have a preoperative consultation with the plastic surgeon to determine the additional measure if anything can be done. Another method is to do a Shams incision when you have such a scar over here as I have shown. So that will help us post-operatively. Medial parapatellar approach is the workhorse for the revision knee surgeries. Other approaches which are commonly used are the tibial tubercle osteotomy and VY quadriceps or patella turn down approach. Worth mentioning here are the mid-vastus and sub-vastus approach which are commonly done in the primary knees, but these approaches have got limited indication in the revision knee surgeries and are only used for a component revision, say when we have to change an insert or when there is a trauma we have to just inspect the knee. This is the standard medial parapatellar approach exposing the prosthesis inside the joint. Another thing which we should be aware of is the quadriceps snip. It is to perform this maneuver, the arthrotomy is extended obliquely at 45 degrees with the fibers of the vastus lateralis from distal medial to proximal lateral across the quadriceps tendon as it is shown over here. Tibial tubercle osteotomy is done 10 centimeters distally from the tibial tubercle, with it being thick proximally and distally thinner. It can also assist with the removal of stem tibial component inserted with the cement. That is the press fit component, which are less commonly used now, but if patient comes up with this is very useful over here. And to close the osteotomy, we need 3 wires, which is biomechanically more stable, though there are other methods of screw fixation, but are less stable and can develop some complications like flexion deformities. The third approach which I mentioned was the quadriceps and patella turn down approach. In the cases of extreme stiffness where there is desirable, the VY quadriceps turn down procedure can be a better solution. It is also done when we expect more than 2 or 3 surgeries, where we cannot keep the osteotomy open. These approaches can help for revision debridements, revision surgeries until we go and do in the definitive surgeries. After completing the medial parapatellar capsular approach, expose the lateral retinaculum from the edge of the vastus lateralis to the proximal tibia. So this is how it is done, and it can be kept open for in revision surgeries. Component removal of the primary component, mostly time we have a loose component, we don't need to remove, but then when we are dealing with an infection, we need to remove the component and put in a spacer. So implant extraction should be performed cautiously or in a systemic manner to avoid major bone loss or periprosthetic fractures. The first step remains to remove the modular liner from the implant, and removal of the space occupying insert reduces the tension in the patella and the femorotibial structure, increasing the level of exposure. The second step remains the removal of the femoral component. The last step is the removal of the tibial component. So this is how a commonly femur component is removed with us. And now coming on to the reconstruction, the main principle of a revision TK is to minimize the additional bone resection. A multi-zone reconstruction combined with the rational use of cemented and uncemented stem is the vital to obtain the solid and durable fixation. Worth mentioning are the zones of reconstruction over here. Is epiphyseal zone 1, metaphyseal zone 2, and diphyseal are the zone 3 reconstructions. The concept was originally adapted from the work of Morgan and Jones. Worth mentioning again is AORI classification, and is of useful when we do a two-stage revision. Perhaps the bone loss can be assessed and we can have our implants ready for the bone losses that we are going to see. Zone 2, that is metaphysis, is considered the most important zone as for a long-term implant fixation. As it avoids stress shielding phenomena correlating to the diphyseal only fixation. Epiphyseal zone, zone 1, is partially or completely compromised in almost every revision scenario. The methods that can be used to fix the components would be that mostly that stems can be fully cemented and press fit cementless stems. The second most important surgical step is the establishment of the tibial platform. Reconstruction is started at the level of tibia as it affects both flexion and extension gaps. If the medial or lateral peripheral bone defect is present, a trial augment is added under the tibia. The use of porous metal cone sleeves revision systems is mandatory in presence of central bone defect. Peripheral defects can be filled up with cements, augments, and screws or metal augments if the thickness is superior to 10 millimeters or 1 centimeter. Completing the trial tibial reconstruction, the knee is maintained in flexion for a trial femoral component. The new component has to fit the mediolateral width of the residual femur, and resulting the anterior posterior size should be the size which fills better the flexion gap. Constrained in case of component malposition or loosening, flexion extension gaps are unbalanced, resulting in the condition of pseudo instability. The soft tissue envelope is maintained and the component revision allows a correct realignment and fixation. Isolated polythene exchange should be considered for a selected patient in a mild case of global instability of less than 5% recurvatum. It is also a valuable option in case of posterior cruciate deficiency in cruciate retaining implants. In case of congruent polythene liner can be used. As we talked, Vanessa has already told, is now available with many implants. Varus valgus constraints provides greater varus valgus instability and can be used in deficient singular or both collateral ligament deficiencies. Thank you.
Thank you, Abhijit sir. Any questions for Dr. Abhijit? So this marks as the end of our session. I request Dr. Vinay sir to present mementos to our esteemed speakers. I request Saket Jyoti sir come on the stage. Abhijit Pandit sir. We will be continuing to our next session after lunch. Lunch is ready. Next session will be on revision knee arthroplasty and its current concepts. Thank you. Lunch is served.
So after lunch, we'll have one more live surgery along with that session of revision arthroplasty, because unfortunately Dr. Santpure is not here. So since his 2-3 lectures were there in the next session, next session, we'll cover it with the live surgery, conventional total knee replacement by Dr. Ambar Mittal. And let's have lunch and then we'll get together again. Thank you. After the sessions, we can have a hands-on demonstration of Meso robotic system, and there is also a demonstration of the Wallace hip navigation in Johnson & Johnson corner.
multiple use. Then the another technology is the 3D printing. Again, cost is a design software, printing infrastructure, engineering support is there. It helps in complex deformity correction, tumor reconstruction, patient-specific implant, and helps in the improved surgical planning. So it always have a 3D printing as a personalized solution that improves outcome and surgical efficiency. So this is how 3D printing can be used in different areas. It's a personalized solution, improved surgical precision, reduced risk and complication, also have a time and cost efficiency and better patient's outcome. Then another part of technology is smart implant. They are embedded sensors are there. You can monitor that, how much implant is taking a load, early detection of the failure, improved rehabilitation and personalized care. But challenge is high cost with limited long-term evidence of this technology. And smart implants have potential to transform outcome through a real-time insight and personalized care. Then another technology advancement is the digital rehabilitation. We extend care beyond the hospital to improve the patient outcome and patient experience. So from remote, we can, with the mobile application, with the monitoring system, rural and remote population can be assessed for post-orthoplasty rehabilitation. So it's high innovation, clinical impact is high, cost is moderate, but evidence is still growing. So when we see this cost-value metrics of the different technology, robotics high cost, evidence is its value is moderate. Navigation, moderate cost, evidence is moderate. AI, moderate cost, high potential is there. 3D printing, moderate cost, but high potential or high value in selected cases. Smart implant, cost is high. Evidence, it is emerging. Telerehabilitation, cost is low, but again, it is a high value. So this is a cost-value matrix. When we see the Indian perspective, it is always challenges are there because of the resource constraint, high patient volume, and cost-sensitive healthcare system. Technology must deliver real value to be affordable and scalable for India's diverse healthcare need. Then, what is the best outcome at the lowest sustainable cost? Patient outcome, cost effectiveness, it should be able to fulfill the quality matrix, long-term implant survival, and patient satisfaction. The goal should be deliver the best outcome at the lowest sustainable cost. In the future direction, technology likely to deliver high-value AI-assisted decision support, predictive analytics, personalized implant is going to come, remote monitoring will be there, digital rehabilitation will be there, and this all should be based by evidence. Robotics for routine procedure, smart implant and AR-guided surgeries, they are further validation, but we need them evidence backup for their value for what we are spending on them. So the key takeaway is that neurotechnology is not synonymous with better outcomes. Value should be measured by patient benefit, not by technological sophistication. Cost effectiveness must guide adoption. Evidence-based implantation is essential. The future of orthopedics lies in value-based innovation rather than technology for technology's sake. Better outcome, sustainable cost, and meaningful innovation, it is a path forward for orthopedic care. The true success of innovation in orthopedics is measured not by what it costs, but by the value it creates for our patients. So patient first, evidence-driven, value-focused, better outcome together. Thank you very much for your patient hearing. I think I have justified with the topic.
Yes, sir. Thank you very much for enlightening us. Our surgery is ready. Can we shift to the auditorium? Yeah. Dr. Ambar?
Yes, sir.
Are we audible? Hello? Operation theater.
हेलो.
Yeah, you can start.
पर मुझे कुछ आवाज़ नहीं आ रही यहाँ पर.
हमको आ रही है.
हाँ हाँ. चल तो सही.
Start कर दीजिए please.
Okay. नहीं अभी विनय सर को बोला ना आवाज बोले उधर से.
Yes, yes, yes. We can hear you.
तो विनय सर की आवाज थोड़ी सी बढ़ा देना.
हाँ. We can hear you. अंबर की आवाज.
हाँ सर.
So can you show the X-ray what we are doing?
X-ray दिखाना. Sir, it's a routine, straightforward primary OA knee.
Okay. So she is 58-year-old female and having osteoarthritis both knee. So in such case, you usually do both the knee together. Bilateral total knee replacement because both the joints are affected.
Yeah, most of the cases.
Okay.
विनय सर की आवाज और बढ़ाना यार.
So, sir, we are discussing among us. You can continue. So, how many of us do bilateral total knee together? Is there any criteria?
If the patient is euglycemic and if the BMI is good enough and there is no comorbidity, I prefer to do bilateral together.
BMI criteria, sir? How much you will?
Say by 26, not more than 26.
Okay. Okay. Sir, do you have any point?
The patient is not comorbidity and everything is not there.
Is age any criteria?
Yes, yes. If advancing age is there, then probably we should go for a 2-stage. And since we are doing most of the patient under Ayushman at our Arvindo, where Ayushman allows only one, so we are not having much study on that basis. We are doing only single stage.
Nice.
Okay. So, if the patient is fit, younger,
yes, it is cost
age,
effective.
doing both the knee together is a cost effective.
Cost effective, better recovery and better rehabilitation also for the patient part.
So, we are seeing here Dr. Ambar is doing it a sub-vastus approach. Any tips for this, Dr. Ambar?
Yes, sir.
Any special thing to be considered while doing a sub-vastus total knee?
Sir, patient selection is most important.
Mm-hmm.
You do not want a very muscular patient and you go for subvastus. Better would be medial parapatellar in those cases. That's my only contraindication, and in cases of revision surgeries. Otherwise, majority of my surgeries are subvastus only.
Okay.
थोड़ी सी कटिंग बढ़ाना यार. कितनी कटिंग?
In our previous edition of MAC, Dr. Ambar Mittal has shown us Pixie demonstration.
In the same theater.
Yeah. So what you are doing right now? This is.
I'm clearing the suprapatellar fossa.
Okay.
This is all.
If you have somebody have any question regarding the approach or exposure, you can ask directly.
Sir, can you ask in the audience how many of them does subvastus?
So, two surgeons here are doing subvastus, one is doing midvastus, and rest all are middle parapatellar guys.
Okay.
We had a lot of discussion because of your internet. You got a lot of time.
Yeah.
So in such case, when we find a varus knee, it's not much of the varus, but what are the important tips to?
Sir, minimum releases. Sir, is it okay?
Yes, yes, very nice.
Visibility is good?
Very good, no problem.
So taking out the osteophytes. Bye. So I have not gone beyond the mid plane. You can see I have just releases till the mid plane only.
Okay.
I have not gone posteriorly. Mop. Forceps.
Now the most important step is to gently flex the knee, because in Savastas is always tight, so externally rotate the foot while flexing. Nibbler, please. Tocha aur ho dena. Cautery. It's always better to remove osteophytes before the cuts, because many times when you take the cuts, it takes part of the condyle with it. So I always mark with a cautery, and then.
You are doing a femur first?
Yeah.
Okay. What do you prefer, femur first or tibia first?
Section. हैमर बड़ा नहीं है रे? चल इधर आ जा, पैर पकड़ना.
Anybody here who does tibia first?
I think Vinay sir, previous surgery was cruciate retaining, am I correct? So we will demonstrate this, the PS knee.
Okay, so this is subarctus and PS knee. And the previous one also was the tibia first. This is the femur first. What are the advantage of doing femur first?
It gives you more space for tibia retraction. I also check for the femur size here, just a rough check. So this could be a D femur, let's see. Now I am taking out the cruciates.
You always do the PS knee or sometimes CR also?
Sir, majority of my knees are nowadays are PS, but previously I used to do most of my knees as CR.
Okay, so here the things are mostly people are shifting from PS.
Sir, the results are, I think if you see
results are same, results are not just an argument regarding the bone conserving. If you do not take the box out, little more conserving. That's it.
Okay. Gently, gently. Cautery. यार कॉटरी देखो यार थोड़ा सा कटिंग अच्छी.
You are marking a
पकड़ के रख छोटू. थोड़ा सा बढ़ाना. बस राइट. हाथ हटा छोटू, हाथ हटा. चलो.
How much cut you take for the femur, for the tibia?
Sir, it is 8 millimeter.
8 millimeter from the normal side.
Yeah, from the healthy side. Nibler. Okay. Remove. Take out the pins. So my distal femur and proximal tibia cuts are done. Now I will take out the meniscus. So I take out my meniscus in extension.
Before taking the pins out, you check for the gap.
Sir, best judgment is your eye. So I know my gap is sufficient. Can you see the gap?
Yes, we can see that.
So no need to put unnecessary spacer and rub the bone.
But for the beginner or
You
people
can put
like-
it. Yes.
Not everybody has calibrating eyes like you.
नहीं सर ऐसी कोई बात नहीं है. I have seen many people doing it and then they damage, they rub this surface of the tibia. So like for last, I don't remember when last time I used it.
I always check it because it gives me an idea about the cuts and size of the insert, what we need to do.
Sir, these are small pearls that when you grow old, you choose
I'm
to
not
select.
getting older.
Arre, sir.
That is the problem.
Sir, your hair tells a different story. Femur sizer. So now we'll do the sizing of the femur part. Pin. One important tip is you always make sure that this screw is fully tight, as much as tight as possible, because if this is loose, you will see there is a gap here. So that will lead to a wrong size and you will end up notching the femur. So always try in Merrill system, always try to make it fully tight so that you do not notch. And see, it is coming D, what we have thought.
Yeah, you have fair idea about the size. And you can
Like I said, sir, your eyes are the best judgment.
Yeah. Number reality.
चलो चलो भैया. I hope audience are not sleeping after a delicious lunch. चलो. And always protect the MCL. I also don't check for notching. Can you see the grand piano sign here? Beautiful.
Yes, we can see.
Sir, I hope my speed is okay, not too slow.
No, it's too fast.
All osteo. Box. Trial. करो हिम्मत करो धीरे धीरे So can you zoom out? Can you see the alignment, sir?
Yeah, we can see that.
ऊपर से दिख जाए.
Yeah.
Okay. This is full flexion and the tibial tray is not lifting.
Okay. So it's well aligned and stable.
Yeah.
Thank you, Dr. Ambar. Thank you very much. You have finished the surgery very fast.
Thank you, sir.
Somebody is saying your 20-minute technique is really great. Thank you.
Okay,
Thank
sir.
you, Ambar.
Thank you, sir. Thank you.
I'll suggest an expert surgeon like him can do things very easily. To start with, we should check each and every step, extension gap, flexion gap, because he has enough experience, he can do it like that he is performing. To start, we should check each and every step, dissect less, check it, if needed, we can dissect more. Thank you, Dr. Ambar. Now we'll move on to another session.
Okay.
Like So I would like to invite Dr. Ashish Goya sir for his talk on newer concepts in implant design, MS, MP and QC design. Dr. Ashish Goya sir.
The post-lunch lectures are good to sleep, and the talks by a professor is always boring, and the talk on the kinematics is something which is beyond or difficult to understand. So it's going to be a terrible triad. Thank you, Vinay and the team MAC for giving me this opportunity. So I'm going to talk about newer implant designs. Basically these three types. There are many minor modifications. So we'll keep it simple. We'll just understand two things: why a newer design is required and what are the options available. We'll just cover these 2 points. So why a newer design is required? As we have heard since morning that not all patients of TKR, they are satisfied despite the right surgery being done, despite a good implant survivorship. Almost 15 to 20% patients, they are not happy with their knees. So the whole thing or the whole work is being done on making these patients happy. And that's why the search for new implant is on the way, that we modify these implant in such a way that your patient is happy. And now the zeal is toward reproducing the normal knee kinematics. Your implant should work as a normal knee. That's the key thing towards which the people are working. And there has been a change in the philosophy of the alignment. That's why there is a need to change the insert or the implant design. And now we have better polythene, better material is there, so we can play with it. Earlier it was not that strong material available with us. So the journey of TKR has moved from just a pain relief to a implant which is surviving better for lifetime of the patient, to improved biomechanics by these measures, and now the concept of personalized knee biomechanics or knee kinematics. So it is kind of individualized to each and every knee we have been hearing since morning. So what are the different options available for these newer options as we talk of? So the first one is the medial pivot joint or medial pivot poly. So it's a highly conforming design. As Hemant sir told that the medial side we just create a ball and socket type of thing when we do a uni. So similarly in a TKR design also, the poly is modified in such a way that it acts as a ball and socket joint. So the medial compartment acts as a ball and socket joint, and the lateral compartment is not that conforming, and so the medial compartment becomes as a pivot, and the lateral compartment has some degrees of translation. So it is somewhat very much similar to the natural knee. So that is why this modification in the poly has been done. So the design characteristics are that it's a asymmetric articulation. The medial side is conformed and the lateral side is not that much conformed. So what it is giving is a anteroposterior stability. So the normal femoral anterior translation which takes place in normal PS and CR design, that is being taken care of, and it improves the function or longevity of the implant as well. And as it can be done with the PS or CR, I mean cruciate sacrificing or retaining, so the bone preservation is there. So what kinematic or overall outcome advantage we have with this, because it has a normal screw home mechanism, it has a normal femoral rollback mechanism with this design, so it mimics the knee very closely to a native knee. And it increases the range of motion because of these factors, and the stability is better. That fear, as we were hearing in the morning, the concept of mid-flexion instability, that takes care of that part also. And the patient, since they don't have to kind of, you ask the patient who has undergone a total knee, he takes a longer time to kind of adjust to that new knee. So these patients, if we use these kind of thing, the patient satisfaction is higher because the knee kinematics is similar to a native knee, and he don't have to take time to adapt to it. Then there's a medial stabilized knee, the second type of modification. So if we see these kind of knees like medial congruent, medial stabilized, medial pivot, they are interchangeably used. But the concept is they, in finer details, if you see, they have different degrees of conformity. The kind of male and female construct is there, different degrees of restraint is there. So the medial congruent, it's not similar to medial pivot. It has a deep dish, its concavity is more, the anterior lip is higher, but it doesn't give that much of stability. It has some amount of translation, unlike the medial pivot one. So that's the medial congruent or medial stabilized concept. Then another concept is ultra congruent. Till now we have seen that the medial side is congruent, lateral is not. Here in this design, both the medial and lateral side, they are congruent. And there is a high anterior lip, as we can see here. And this highly conforming deep dish design, they can be used with PCL sacrificing or PCL retaining thing. We need not to substitute it with the cam and post mechanism as we do with the PS designs, but they give a restraint similar to the PS design, so that the normal femoral roll back takes place. So the design characteristic is that it's a deep dish, and it kind of mimics that ball and socket geometry, and we build the polyethylene anteriorly so that it prevents that femoral anterior translation which takes place with normal PS and CR. So the benefit is that it increases the stability, and when we talk about stability, we are talking about anteroposterior instability. And because of that conformity, the contact stress is less, the polyethylene wear is less, and the range of motion is also increased because of increased femoral rollback. The kinematics is better, the patient satisfaction is better. Another, which is a pretty complex modification, it's a bicruciate retaining. It's not a newer concept, it came in 1970s, but it was dropped down in 80s, and it is now again coming up that you don't sacrifice the ACL, you don't sacrifice the PCL, you preserve those mechanoceptors so that patient feels as if nothing has been done to his knee, his normal knee he is surviving with. So the kinematic restoration takes place with bicruciate kind of design. The proprioception is maintained, so the balance is good, and the patient satisfaction is good with this bicruciate type of design, but it's very technically demanding, and it comes with a lot of complications. So the literature about these kind of medial stabilized designs, both of them are kind of very successful, very gratifying results, and there is no difference whether you sacrifice the PCL or you retain the PCL. This is a recent study published last year about these kind of medial stabilized designs, MC, MS or UC. In all of them, around 6,000 knees were involved in this meta-analysis, and there is no difference in between these three types of designs, MC, UC and MP. And there is no difference whether the PCL was sacrificed or retained. So that's all the literature support for this. So the take home is that we should understand that why we are looking for this newer design concept, what are the options available to us, and before dwelling on to them, we should have evidence to use them, and we should have expertise to use them properly. So that's all about the newer implant design. And on behalf of MP chapter, as Honorary Secretary of MPIO, I request all of you to please spread a word about Bhopal as a host for IOCon 2028. Thank you very much.
Thank you very much, sir. Any questions to Dr. Ashish, sir? Thank you, sir. Next in the line, I would like to invite Dr. Gaurav Yadav to talk about the personal alignment versus the mechanical alignment. Dr. Gaurav Yadav.
Good afternoon, dear seniors and colleagues. Thank you, Dr. Vinay sir and Mac, for inviting me to give a talk on personalized versus mechanical alignment. Much has been discussed about these strategies by Dr. Akhil Arora sir in a very comprehensive way. I'll just rush to the all the types of alignment. So personalized alignment, as you can see, is a blanket term or a generalized term used for alignment strategies other than mechanical alignment. Now, this is not a versus battle between mechanical and all other strategies, otherwise we know what would be the result. If we look at the history, when John Insall first described the philosophy of total knee arthroplasty, neutral mechanical alignment strategy, the goal was simple, to make the deformed knee straight. And to do that, we cut the tibia and femur at 90 degrees to the mechanical axis and make a neutral hip-knee ankle hip-knee ankle line and a neutral joint line obliquity. The idea was to prioritize symmetrical compartment loading to facilitate prosthetic longevity. And we can see from the result, the long-term survival rates of mechanical alignment are very much promising. We all know the excellent track record of mechanical alignment for implant longevity, but not all the patients undergoing total knee arthroplasty were satisfied. Patients do complain of pain, their knees did not feel normal, and they had difficulty with normal gait. Because we had to release soft tissues, collaterals, we altered the joint line and the knee kinematics. We all know that the forgotten knee score is far, far less than the forgotten hip score. So the various studies shows dissatisfaction rate ranging from 5% to 25%. And this dissatisfaction rate is not just because of one cause. There are n number of causes for this dissatisfaction, but sometimes only one cause gets highlighted. When we look at this paper from Sam McDessie from Australia, we can understand that there are 9 phenotypes. We all know about that. And from Here, the concept to reproduce normal knee alignment laxity, in a normal knee alignment, the laxity and the knee biomechanics started taking place. People started thinking of anatomy preservation, restoring the pre-arthritic knee anatomy and functions. So what can be done to improve? Around 2010, two brilliant minds in arthroplasty started working on alignment strategies. One of them is Dr. Professor J. Bellemans, who gave us the concept of constitutional varus. In his study, he found that 66% of males and around 80% of female has some degree of varus in their normal knees also. At the same time, around 2010, Stephen Howell from USA started working on kinematic alignment, and he was the pioneer of kinematic alignment. He said instead of forcing the knee to neutral, he restored the patient's pre-arthritic knee anatomy. His concept was resurface the knee rather than realign the knee. So what is this kinematic alignment concept? I call it the concept of esoteric lines. These lines are flexion extension axis of tibia, flexion extension axis of patella, and internal external rotation axis of tibia, which is on the medial condyle. Now these lines are not easy to find. If you give someone a bone and ask them to point out these lines or axes, he won't be able to do it. You require a CT and special software to find these lines. What did Stephen Howell do in his concept of kinematic alignment? It aims to preserve the native obliquity of joint line and constitutional alignment. We have to preserve it by putting the tibial component in varus most of the times and femur in valgus. He did not give any rotation to the femur implant. And when Howell described it, he did not put any limits in the amount of varus. He could cut tibia to any extent to get a kinematic aligned knee. He did more of an unrestricted kinematic alignment. So we were seeing a shift in the TKR technique because why we were needing soft tissue balancing, it was to create a mechanical aligned balanced knee. We were putting the component in 90, and to accommodate that, we had to release soft tissue. But in kinematic alignment, we did not need soft tissue release. We see some promising results from study by Stephen Howell with 97.5% of survivorship. In this balancing continuum, you can see on the one side we have mechanical alignment as described by John Ensal, and on the other side, far right, we have unrestricted kinematic alignment with most of the bone cuts. As people started using kinematic alignment, concerns started rising. Because we put tibia in so much of varus, there were questions arising about how long the implant will survive. But still, kinematic guys did not worry about this and would go even beyond 5 degrees of varus in the tibial component. From this study by Professor Bergman, where they measured intra-articular load in vivo, we learned that there is a direct correlation between lower limb alignment and intra-articular load. Then the question arises, should all patient anatomies be reproduced blindly all the time? We should not, because some pathoanatomies exist in knee, and it should be modified to be compatible with our current implants. These understandings about different anatomies and limitations of kinematic alignment laid down the rules and boundaries for restricted kinematic alignment. It was given by Dr. P.A. Vendotoli, who was a devotee of KA, but he was nervous of KA. And worrying about the extreme placement of components, Vendotoli in 2016 gave us the concept of restricted KA, where he set some boundaries to align the knee. It is best performed with intraoperative direct feedback with computer navigation or robotic, or pre-op planning as with personalized instruments. He laid down some principles. We can see the HK axis should be between plus and minus 3 degrees, and the joint line obliquity should not cross 5 degrees. We have to restore native laxity and preserve the anatomy or resurface the intact compartment. With these boundaries boundaries by Vendotoli was able to get good result as shown in this study. The kinematic alignment group showed no significant knee kinematic differences compared to healthy knee in sagittal plane range of motion. Maximum flexion, adduction, abduction curves or knee external tibial rotation were also normal. Conversely, the mechanical alignment group displayed several significant key knee kinematic differences to the healthy group. The post-operative Coos score was significantly higher in the kinematic alignment group compared to the mechanical alignment group. On the balancing continuum, we have then restricted kinematic alignment just beside the unrestricted with a limited, with the boundaries. At the same time, mechanical alignment guys also started thinking that what if we can adjust the component and not release too much? For example, if there was a serious varus deformity, can we leave it with some residual varus? So the concept of adjusted mechanical alignment came into the play, which was given by Dr. Bellemans. There was another concept of restricted inverse kinematic alignment given by Philip Vinok de Grave. He was concerned by the Ka principle of tibial recuts for balancing. So the restricted inverse kinematic alignment is nothing but just the inverse of kinematic alignment, where the balancing is done over the femur instead of tibia, and we adjust the femur in coronal and axial plane to balance extension and flexion gaps. Then came the alignment, which is a combination of everything, typically requiring a robot, described by Faraz Haddad and Matthew Abdel, who told us that you have to fit the component inside the existing soft tissue envelope to have a balanced knee throughout the range of motion. And the concept of functional alignment came into the play. There are some boundaries involved in this also, as popularized by Sebastian Lustig from Europe, and are now followed worldwide while doing a functional alignment. These are those boundaries. So on the balancing continuum or a spectrum, on the one hand we have purely mechanical alignment, and on the other hand we have unrestricted kinematic alignment, and in between there is a balance between soft tissue release as well as the bone cuts. So do we need to change our strategy? Of course, we have to give a thought about patient's phenotype, constitutional varus, and we have to choose that alignment philosophy that gives a balance between coronal alignment, gap balance, and biomechanics. Before I conclude, I want to ask how to approach these kind of severe abnormalities, deformities. How to know their native alignment. It is difficult to know their native alignment, as these are the types of patients we get to see in India. So we do not know their native alignment. I feel it's better to do a TK with a mechanical alignment in these patients. So what is the ideal alignment for a patient? The one which reduces the knee adduction moment of force, one which protects the poly and the cement from excessive loading, prevents instability and pain resulting from unbalanced ligaments, and also gives a long-lasting implant. Thank you so much for your patience listening. Thank you, Mag. Thank you, Dr. Vinay sir, for inviting me. And I leave you all with a question. Are 20% of patients actually dissatisfied following total knee arthroplasty? Thank you so much.
Thank you, Dr. Gaurav. Any questions to Dr. Gaurav? Thank you. So we have 2 case presentations left with for the today's program. I would like to invite Dr. Jay Sharma for his case presentation, Dare to Dare.
Good evening, Dare. Good evening, all the dignitaries. Thank you, Vinay sir, for giving me this opportunity. So I'll be presenting 3 cases of acute infection after knee replacement, in which we did a Dare procedure. This is an evidence-based discussion, what we did and what results we got. So the objective of Dare is to get a rapid reduction in the intra-articular bacterial load. We do a complete synovectomy and debride of the joint of the necrotic and infected tissue. We disrupt and remove the immature biofilm and preserve the the implant stability, and just change the inserts. The success rates are highly variable between 30 to 90%, and appropriate patient selection remains a controversial topic. So we are presenting these 3 cases. The current evidence says that post-operative acute infection would be an infection which is presenting in 4 weeks of the index surgery, acute hematogenous spread would be between 3 weeks would be of a 3-week duration, and we do a DARE procedure only when the implants look to be stable, the soft tissue envelope is intact, the organisms are known, and symptoms are not more than 3 weeks. So this is the first case. He's a 70-year-old gentleman, psoriatic arthropathy. He was operated in 2023 with a subvastus approach, and had a hematogenous spread after a angioplasty procedure. He was on blood thinners, and the presentation, he had all the inflammatory signs positive, the signs and symptoms positive. CRP was 52, ESR 80, the polymorphonuclear cell percentage was around 82%. It was a methicillin sensitive Staph aureus infection, which was sensitive to common drugs. The approach was the same index approach, the subvastus approach, and followed by vancomycin and tigecycline intraoperative, and for the first 4 weeks of the therapy. We gave vancomycin for 7 days, tigecycline for 1 week, rifampicin and linezolid were followed for 4 weeks, followed by rifampicin and cotrimoxazole for the next 6 weeks. After 2 months of surgery, the antibiotics were stopped. CRP is within normal limits. The patient does not have any pain or swelling. Another case was a 54-year-old female. She was a rheumatoid arthritis case, a primary ONE with FFD of around 30 degrees. Primarily, we gave her a stemmed knee. In the pre-op workup, the CRP was raised. She had no symptoms. Her albumins were low, and blood picture was normal. But during the surgery, we found pannus on the joint, so we got a sample intraoperatively, which came out to be MRSA positive. Though the medicines she was susceptible to were quite a few, so we went ahead with the surgery, and during the surgery, all these samples were taken. Post-operatively, at around 3.5 weeks, we had symptoms. She had swelling. Again, the MRSA came positive. We followed the same protocol in which we did not use drain, ceftriaxone and tigecycline for 1 month, and rifampicin, cotrimoxazole for the next 4 weeks, next 10 weeks. These are her post-op 3 months follow-up pictures. There is some lytic lesion on the medial condyle, but she's asymptomatic as of now, and because of the stem, I don't think she would have any other problems, hopefully. These are her walking videos. CRP has come back to normal. This is the third case. Actually, my first case of knee which got infected. She was an 82-year-old diabetic patient. HbA1c was normal, was well controlled. She had bilateral OAs and some FFD. She was perfectly healthy with hardly a 0.5 centimeter margin of the marginal necrosis. We gave her a waterproof dressing. She had to come on 17th, but came on 23rd with a wound on the knee, which developed sinus later on. But everything was within the 4 weeks period, so we dared to dare a dare. And the tibial base plate was visible from the sinus, so a flap, gastrocnemius flap, was done by my plastic surgeon colleague, and then gave her 6 to 8 weeks of rest. These are her almost 3 years post-op pictures. She's doing well. Everything appears to be okay. In summary, CRP is back for each and every case, though the time is quite less. What we followed was we did a debridement synovectomy. We used hypochlorite solution, the Dakin solution, in which we mix 5 ml of the sodium hypochlorite in 1 liter of normal saline. It has to be kept in contact for maximum 3 minutes because it has tissue toxic features. So 3 minutes is the deadline. The hydrogen peroxide wash and the betadine wash, the 0.35% betadine wash as told earlier. Along with that, we did a physical scrubbing of the implants. The irrigation for the last phase was with 3 liters of normal saline pulse lavage, and poly exchange was done. What predicts a successful DARE? The positive factors are early intervention, exchange of the liner, low virulence organism, stable implant, and acute symptoms. What are negatives? MRSA, so far so good. One of our cases, an MRSA case, but she's doing fine. Sinus tract, 3 years down the line, she's doing fine still. Delayed treatment and loose implants are a contraindication for DAIR. The current guidelines say that the areas of agreement are acute infection, implant which is stable, and modular exchange is possible. Controversies, the duration of cutoff. Some people are doing, as Chaudhary sir said, they are doing 2 stages of the debridement and 3-stage replacement procedures. So in those cases, some people have attempted DARE but are not very successful. Resistant organisms and repeated DARE, either doing it twice, thrice, it is a controversy. So the take-home message is it is a viable, valuable option if you are choosing in acute phases. The timing is very critical. Poly exchange has to be done always. The host factors like the host factors and the organism factors are of a major concern, and you should avoid DARE. It successfully evades a few of the major revision surgeries. Thank you.
Thank you, Dr. Jay. Any questions to Dr. Jay? I have a question, just one question. How long you give IV antibiotics and how long oral? And you use rifampicin. Any specific reason or sex? One more newer antibiotic I heard about, the Nuvoc.
Levonorgestrel.
Yeah. So what, do you have any experience of that?
I have experience of levonorgestrel in 2 patients of trauma. Mostly it is for gram-negative bacilli. We use in enterococci. The patient had huge swelling. We removed the implant, and the sinus was still persisting. So we gave the patient oral medicine. He responded very well.
They also say that antibiotic breaks the biofilm and then.
Sir, it is, but the cost effect.
Yeah. Thank you. Thank you very much. Thank you. Thank you, Doctor.
Sir, do you use antibiotic releasing calcium beads like Stimulan?
Stimulants are, if I'm doing a stage procedure, the first stage I would definitely use, but in a case of DARE, I have not used. 3 cases is very small for getting too much of an exposure.
So I always use those antibiotic beads which are absorbable, stimulant sort of. But you have to use the antibiotics wisely in those things, because sometimes if you over mix the antibiotics, it fails to integrate and get.
Also, it has to
right.
be stimulant.
Yeah.
If you're using the local, the Varanasi ones, they'll have their own reactions. They'll lead to serious discharge for a longer time.
So original stimulant is better than. Thank you, Dr. Jay. So I would like to invite our last speaker of the day, Dr. K.K. Nima, for his talk on the implant selection in revision TK.
Thank you, Vinay sir, for the opportunity. And in the morning we started with unicondylar, and now we are finishing on revision. So this is how life is. And if you do primary, we will have to do revisions as well. So as we know, there are multiple indications for revisions, and so it could be many causes like infection, aseptic loosening, fracture, periprosthetic fracture. So general principle of revision TKR is to clarify the cause of the failure, correction of the bone defects, restore the limb alignment, and achieve soft tissue balance and restore the joint line. Our goal in revision is to achieve stable fixation of the implant, adequate soft tissue balance, and optimal patellofemoral articulation. So selection of appropriate implant is done by magnitude of the bone loss, integrity of the ligaments, functional demand of the patient, and potentials for re-revisions. So as we know, we have discussed AORI classification of the bone loss, type 1, 2, 3. So in type 1, there is minor femoral and tibial defect. In type 2, there is damaged metaphyseal bone loss. And in type 3, there is deficient metaphyseal segment, compromising a major portion of either femoral or tibial condyles. So type 1 can be dealt with primary implants, but if we have type 2 or type 3 kind of defects, then we might require special implants like sleeves, cones, augments, wedges. So according to Morgan-Jones of fixation, choice of implant depends upon the ligament stability and the amount of bone loss. Dual zone of fixation is important for long-term survivability and good results. So management of bone loss can be done by metaphyseal sleeves, cones, blocks and wedges, and tibial stems. So augments, the primary purpose of the augment is to replace the peripheral marginal bone loss. It is used in uncontained type of defect, in defects where there is medially there is bone, laterally there is no bone. So in this kind of defects we can use. It is completely mechanical type of fixation and no bone ingrowth is seen. Wedges versus blocks. Block augmentation better than wedges in strain distribution, tensile deformation rate, compression deformation rate, and shear deformation rate. So sleeves versus cones. Metaphyseal sleeves fill a metaphyseal defects and stabilize the implant. So sequential broaching is done until a rigid fixation in the bony canal is obtained. It is a mechanically linked device and improved implant stability and alignment. Whereas the cones, it fill a metaphyseal defects, porous surface is there for long-term biological fixation, and fixation is independent of the tibial and femoral stems. Sleeves, indications of sleeves are elevation of the joint line, management of severe bone loss. Sleeves give fixation in the zone 2, and it is made up of titanium with synerted beads of 50 to 80% porosity on the surface. But the problem with sleeves is it is radiolucent line is seen, so you need to have regular follow-ups and long-term follow-ups. Intraoperatively, while preparing the sleeve, there can be fractures, and removing a sleeve is very difficult job. So there are good results seen mid-term and long-term with sleeves. Coming on to cones, so tantalum as a metal has high volumetric porosity, low modulus of elasticity, high friction characteristics, and hence uniform load distribution and no stress shielding. So these are various type of cones available in different sizes, and they can be made customized as well. So technique is, when we have a defect, it's an ice cream cone sort of a defect. So there is a host bone. Beside it, we put a mosserized bone graft. Inside it, we put a tantalum cone, and then we fix the implant with a cement. Then there is, to balance the gaps, we have femoral augments, we have distal femoral augments, posterior femoral augments. We have tibial wedges, sizes 1 to 6, thickness 5, 10 and 15, maybe downsize relative to tray, and universal for use on medial, lateral or both sides. Tibial stems are used to support for the implants. It gives fixation stability, distribution of the shear stress, and reduction in bone cement stress. So there are 3 types of stems types which can be used. It could be cemented, press fit uncemented, and hybrid stem. So hybrid stem is the most modern type of fixation and used in modern revisions. Cemented stem are used in osteoporotic bone. Press fit is used in when you have a good diphyseal connect. and hybrid is the way to go currently. So biomechanically, if you have stem less than 40 millimeters, it is insufficient micro motion control. 60 mm and above increase stress shielding exponentially. So once we have got two zones of fixation coming onto the implant, we see the constraint of the implant. So either it could be a primary PS, semi-constrained CCK. So when there is flexion and extension gap and ligaments are not that good, we can go for CCK. And in type 2 AORI, hinged are of two types. When there is flexion extension mixed gap, the flexion extension gap is more than 10 mm, then we should go for hinge kind of an implant. Hinge are of two types, fixed and mobile bearing. And when we don't have any metaphyseal bone for fixation, then we should go for tumoral prosthesis. So this is the revision TKR scenario. So if AORI 1 with intact ligaments, we should go for a posterior stabilized implant. Metaphyseal damage with AORI 2, good fixation in the metaphysis. Collaterals are okay, go for a PS implant. Collateral has lax but functional, then go for a CCK kind of implant. AORI type 3, metaphyseal sleeves and cone has to be used. If ligaments are functional, CCK kind of an implant. If ligaments are not functional, then go for a rotating hinge. If you are not able to do metaphyseal fixation, then you should go for directly tumor prosthesis. So these are few of our cases, not done by me, done at our institute. So as you can see, there is severe bone loss and loosening of the implant. So we went in, we used a CCK kind of an implant. Another case, severe bone loss. So we went in and did sleeves with hinge implant. Thank you.
Thank you, Dr. Nima. Thank you very much all the speakers and delegates. So for this last session, we'll just like to felicitate our speakers and guests. After this, we'll have a small tea break and then we can have demonstration of the sawbone model of the meso and Wellis hip navigation. So I would like to invite Dr. Saket Jati sir, Dr. Abhijit and Dr. Arjun. Please come on the stage to felicitate our faculty. First of all, I would like to invite Dr. Amay. Dr. Ashish Goya sir, please. एक और गुलदस्ता तो ले लो सर. एक बार फूलों का स्वागत तो करो. डॉक्टर गौरव यादव. डॉक्टर जय शर्मा.
Dr. Jay Sharma.
I'll invite Dr. Nikhil also. Dr. Nikhil and Dr. Akhil, please come. all the faculties. Just have one photograph. And most important, our two sponsors without whom this conference would not have been done. Mr. Akhil को फूलों के गुलदस्ते Mr. Prashant from Johnson & Johnson. Prashant, Puneet, आप दोनों आ जाओ please. Last but not the least, Mr. Ilhan Qureshi, RSM Merrill.
I think the most important person in this whole MAC 2026 is Dr. Vinay Tantue sir. We should give a big round of applause for him.